Good morning. All of you know Pragnesh very well, the crux of this man of the match of this GMACON 25. He is a national president, Federation of Family Physician Association of India. And I request Dr. Pragnesh Bhai to start the session.
Yeah, it's fine. This is the next era of the family practice. So, in spite of we are reaching to the moon, there are some technical errors happening in the earth. So, thank you, Dr. Ketan Bhai, for a kind information and kind introduction. Today, I will talk on next era of family practice. So, what is the future era of the family practice? So, to start with that, the basic requirement is trust, knowledge and skill. Trust of the patient, knowledge and skill. They are the base of any specialty or practice. And apart from that, well-equipped setup, social media marketing for the family physicians, telemedicine, electronic medical record and use of AI in day-to-day practice. You all can see the AI generated Rangoli at the entry of the hall. So you can form like anything on AI, just give the command and you can get an image what you want. So what is the benefit of the well-equipped setup? I already told that trust and knowledge is compulsory. As we all know, we all have a trust in the God since our birth. So, and we all know about the history of the Ram Mandir. So, in 2015, there are 4 CR footfalls in the Ram Mandir. And now, in 2024, in first half, there are 11 CR footfalls in the Ram Mandir. So, what is the reason behind that? It is the infrastructure, facility created by the local government, connectivity, awareness and marketing. So, these all things are the required in our profession also. For the well-equipped setup, there may be must be a reception, waiting room, and well-furnished consulting room, trained staff, proper display of timing and facility, tips of corner and awareness corner must be there in the clinic and waiting area. Nebulizer and glucometer, these are the basic requirement. Weighing scale, ECG machine, pulmonary function test, spirometer, otoscope, ophthalmoscope. These needs a little 3 or 4 hours training to how to use otoscope and ophthalmoscope. Then, if the female practitioner, obs and gynec examination facilities should be appreciated. Then, electronic media record, lab collection center and pharmacy, they both are the earning horse for the clinic. Then nowadays there are many companies, they are providing ABPM and CGM and Holter monitoring facilities. So you can have their number and you can use these facilities and give the facilities to your patients. Then extra facilities like dietitian and other specialty. See what happens. Then practicing from 9 to 12 and 5 to 8. This is the routine clinic hours. So apart from this hour, our clinic is locked. So apart from keep the shutter down, I request all of you to create the other facilities at the same place. Other activity requirement by the local government is the mandatory. Now about the social media marketing. Social media marketing can be effective way for the family physician to engage with patients, build a community and promote their services here. Here are some strategies and tips specifically tailored for the family physicians looking to enhance the social media presence. First, to identify your audience. you should know कि आपको किसको टारगेट करना है. सो टारगेट द डेमोग्राफिक्स एंड पेशेंट्स नीड्स. सो अहमदाबाद वाले यहाँ बड़ौदा में मार्केट करेंगे, उसका कोई लॉजिक नहीं है. सो आपको लोकल आपके एरिया में टारगेट करना है. एंड सेकंड थिंग इज पेशेंट नीड्स, जो आपके पेशेंट को चाहिए वो आपको डिलीवर करना है. देन यू हैव टू चूज द राइट प्लेटफॉर्म लाइक फेसबुक, इंस्टा, ट्विटर एंड लिंक्डइन. सो फॉर द लिंक्डइन is for the professional marketing. Suppose if you want to market yourself in the medical fraternity, LinkedIn is a very good option. Then Facebook, Insta, it is good option for to address the patient community. You can have a short videos on Insta, short reel on Facebook. See, just I give one example that I kept one video on the Insta before 4-5 days, and today morning there are 1,40,000 views for that video, and it is about FPNATCON. It is not about me, but it is about FPNATCON. So this is the reach of the social media. Then create a valuable content like health tips, educational post, then myth busting, then patient stories in the frame of the NMC guidelines, of course. Then engagement and interaction with the patients and community. Then if time permits, respond to comment, or you may have a AI generated responses. So this is also a practical way. Then ask the questions. Then live question and answer sessions. Zoom is we all know about Zoom. So you can, if you have a good number of patients, for example for diabetes, and if they have a many queries, then you can create a Zoom session 30-40 minutes and let them ask the questions. Then something about community involvement. Yes, today we did the walkathon and the breast screening a campaign. Such like local events and partnership with other firms and company. So involve yourself in the community involvement. Use visual content like infographics and video. Then maintain professionalism. Patient privacy and accurate information is maintained while doing social media marketing. Then you can, of course, to target the audience. So for example, you select 3-4 communities that, for example, doctor, nurse, then hospitals. Then you have to choose the targeted views, 25,000, 50,000, 1 lakh, 2 lakhs. So according to that, you have to pay for the 1 day or 2 days. So for the 25,000, it is roughly about 130-140 rupees that your video or your graphics can be seen to your targeted audience. Then monitor and analysis of performance. So you can also analyze your tools कि कितने व्यू आए, कितनी कमेंट्स आई. These are also, so according to that you can change your strategy. आपने कोई पोस्ट रखा है और उसमें व्यूज नहीं आ रहे हैं, so you need to change your strategies. Then stay updated. Then you have to constantly stay updated about the social media, all the gimmicks about the social media, like trends and continuing education program which are running in the markets. So in short conclusion, by implementing this strategy, family physicians can effectively utilize social media marketing to enhance the patient engagement, build their practice reputation, and foster a sense of community. Remember, consistency and authenticity are the key to successful social media presence. This is the key line. ऐसा नहीं है कि आपने एक दिन कुछ पोस्ट कर दिया और फिर आप एक साल के बाद करते हो. So you have to plan your post. You have to make your post calendar that every month on 5th or every fortnightly or every weekly you have to make the plan. And there are options that you can, if you have ready material for 4 or 5 sessions, then you can plan the dates and time for that posting. Then about the telemedicines. Now, Government of India Health Department is also published guidelines about the telemedicines, and it makes the thing simpler to address the patients, especially of the chronic diseases, and patients those needs some advice. This is a very simple telemedicine practice. So telemedicine has increasingly become the integral part of the family practice, particularly due to its ability to enhance access to healthcare, improve patient engagement, and streamline the delivery of the services. Here are some key points regarding the intersection of the telemedicines and family practice. Benefits of telemedicine in family practice are increased accessibility, conveniency, continuing care, cost effective, expand reach and enhance communication. See, the best part is that I have met one doctor yesterday. He told me जब वो अमेरिका में बैठे थे तो भी टेलीमेडिसिन करके डेली 10-12 हज़ार कमा लेते हैं. सो यू कैन अर्न ड्यूरिंग योर वैकेशन ऑल्सो if you plan the timing 1 hour or 2 hours. The challenges are technology barriers, so you need to know. Then limited physical examination is the challenges. Then license and regulation you have to follow, and patient privacy is the concern. The application of the family telemedicine in family practice are the chronic disease management, mental health services when you only need to counsel the patient, then preventive care and the pediatric care. Wearable technology, artificial intelligence and triage and broader acceptance. See, this artificial intelligence is we don't know that at what level that AI will advise the patient. Today also if you simply enter the symptoms and ask for the treatment, वो आपको ट्रीटमेंट लिख के दे देगा और नीचे एक लाइन आ जाएगी कि before starting the treatment consult your doctors. So this also, if you writing anything non-scientific, then be aware, because patient can scan your prescription and put on the AI and ask about your medicines. Then EMR and family practice, the silent features of these facilities are you can watch your patient's record from anywhere, anytime and for the long time. That is the major benefit of using EMR. Use of AI in day-to-day practice. You also know to use AI in your practice. That मैं एक सिंपल एग्जाम्पल देता हूँ कि कभी कभी हम सबके प्रैक्टिस में ऐसा होता है कि कोई पेशेंट आया गूगली, हमको भी पता नहीं चलता है कि साला क्या है ये. तो इफ यू एंटर सिम्टम्स 5 or 7 symptoms in AI and ask for the differential diagnosis, AI will give you 7-8 diagnoses. So, and patient if sitting opposite to you, he don't, वो उसको लगता है कि सब कुछ मेरी एंट्री कर रहा है, पर you can do it on your laptop or computer. So, I think this is the long topic. Yesterday, Dr. C.S. Buch discussed in depth about it, so I will not. But the future of family practice is good clinic, AI, updated and social media. Thank you very much.
Thank you so much, sir, for sharing your valuable thoughts. Now I would invite Dr. Jayendra Kapadia, sir, to honor Dr. Pragnesh Shah, sir. I request Jayendra Kapadia, sir, to please stay on stage for Dr. Abhay Dikshit FFPAI oration on challenges faced by family physicians in India and what are the solutions. I would like to give a small introduction of Dr. Abhay Dikshit sir. Dr. Abhay Dikshit sir passed his MBBS from Jamnagar in 1975.
यही है ना?
Dr. Abhay Dikshit sir, please come on stage.
यहाँ से नेक्स्ट होगा, यहाँ से.
So Abhay Dikshit sir, he is immediate past president of FFPAI. He is past president of Ahmedabad Medical Association, branch of IMA. He is current president of Gujarat State Family Physicians Forum. He is also very much active in many organizations, institutions and NGOs. He has organized many conferences and diagnostic camps at various capacities. He is a motivational speaker. He had delivered more than 25 motivational lectures. He had donated blood 65 times. Please give a huge round of applause. I would also like to introduce Dr. Jayendra Kapadia sir. Dr. Jayendra Kapadia sir is President of Federation of Family Physicians Association of India. He is past President of Family Physicians Association of Surat. He is workshop leader for Buzurgo Ka Humsafar, a prestigious project of Family Physicians Association Surat to motivate and uplift life standard of senior citizen. In sports, he represented India in World Veterans Table Tennis Championship at Muscat, Oman in 2023, Asian Pacific Veteran Table Tennis Championship, Bangkok, Thailand, South Asian Table Tennis Championship, Colombo, Sri Lanka, and he is representing Gujarat regularly in National Table Tennis Championship, now playing in 75 plus age group.
Thank you.
He is a national award winner by Mediscape India for Outstanding General Practitioner of the Year in 2012-13 by worthy hands of President of India, late Dr. APJ Abdul Kalam sir. He is winner of Best Clinic Trophy awarded by Indian Medical Association of Gujarat State, year 2007 and 8. Sir, please continue.
Good morning. Thank you for a very kind introduction. And before I initiate my presentation, challenges faced by a family physician in India, I would like to thank Dr. Abhay Dikshit first, because this is the innovation in the Federation that after having given such a generous donation, they have started FFPI oration. And I must thank Dr. Abhay Dikshit and the organizers for having selected me for the very first FFPI oration. Thank you, organizers. Thank you, Dr. Abhay Dikshit, and a very august audience. Dr. Pragnesh very recently, just before me, said that there are so many advances in the field of telemedicine, but the irony of issue is that what are the challenges faced by family physician in our country? No.
ये वाला चाहिए.
हाँ. नेक्स्ट क्या करो?
Yes.
फुल स्लाइड कर.
हाँ, full slide.
फुल ब्लच करे.
हाँ.
ओके. પેલું માઇક આપી દે ને મને આ બંધ કરી દે. ચાલીસ કરી જોઈ લે. Hello. So let's see what are the challenges faced by a family physician in our country. The very first is overburden or workload. Family physicians often cater to a large number of patients due to the shortage of qualified doctors, particularly in rural area. Long working hours lead to family physician exhaust to physical and mental exhaustion. I asked one of my friends, because when I was preparing this presentation, I inquired number of very senior and junior family physicians, that what are the challenges that the family physician is facing at present. And few of them said, my clinic hour is 9 to 1 and 5 to 9:30, and sometimes it reaches to 10 o'clock also. So if we have 14 hours in day, almost we are spending 10, 11 hours in the clinic. So what could be the solution? Increase the number of family medicine practitioners by encouraging more medical graduates to specialize family medicine. General practice or a family practice is a specialty by itself, and it should be the goal of the solutions. And very rightly said, as a theme of this conference, family physician is heart of the medical care. Very rightly said. Inadequate training and recognition. Family medicine is often undervalued compared to other specialties. Do you agree with me or not? Yes. Lack of updated training programs and exposure to newer medical advances. What are the solutions? Strengthen family medicine residency program and CME opportunities. I must thank IMA College of General Practitioners and various units of FPI. Bombay GPA, excellent. Ahmedabad, Surat, Gandhinagar, Rajkot, Ranchi, everyone is doing excellent CME programs that brings a family physician within the purview of updated their clinical skills. Now, important part is this. Government and the National Medical Commission should strictly promote family medicine as a rewarding and essential career choice. See, we have to execute the policy what they form. And if this policy is formed in the favor of any family physician, will be very helpful to all of us. Only few medical colleges in India offering MD in family medicine. This is the irony of fact. And the other irony of fact is All India Institute of Medical Sciences will soon offer MD in family medicine. This is going to be a future. But I must say the Rajiv Gandhi University of Health Science, Karnataka, was probably the first university in our country to start update diploma courses in family medicine. Limited infrastructure and resources. We all agree with it. Many clinics lack access to diagnostic tools, laboratory services, telemedicine facilities. Poor infrastructure in rural settings hampers effective care delivery. Let's see what are the solutions. Provide government subsidies. Very important. See, there are so many segments in our country where subsidy is provided to different segments of the society. So why not to a family physician who is working in a very remote area, very rural area, underserved area, provide them a good subsidy, and very importantly, a loan with a low interest rates to help family physicians to upgrade their clinics. See, when I was presenting the problem and the challenges faced by a family physician in metro cities, challenges faced by a family physician in a bigger cities, in a town and in rural area, everybody's challenges are different. So if every time we are receiving some kind of information every month that if you need to upgrade or update your clinic, we will provide you interest. But the interest percentage is 8 to 9%. And a friend of mine who is working in a very remote area, in a rural area, if you give them a loan at a very subsidized rate, definitely he will come forward to update and upgrade his clinic. Develop public-private partnership, improve infrastructure and diagnostic support. Very important. See, for an example, I am a member of the, what you call DOT program by Government of India. The very moment I refer a patient in the DOT, I have been given absolute updated information. I'm talking about Surat. Updated information that your patient has started AKT, when he completes the full course, whether he has gone to Zine experts, whether any drug resistance, everything, and regarding the patient weight gain. So this is an important of public-private partnerships. This can be possible in other areas also. See, if we can plan a public-private partnership with a software company, some logistics. So this will definitely improve the update standard of family physician, which will help to support our challenges. Financial constraints, family physicians often operate on a very small scale. Yesterday in the meeting, when we were planning to start our program, Ideal Family Clinic, the minimum requirement was stipulated 150 square feet. So, a family physician often operate on a small scale, leading to a financial instability. Patients in rural or low income areas often unable to pay for their services. साहब आपने मुझे 4 दिन की दवाई दी है लेकिन मेरे पास पैसे 2 दिन की दवाई के हैं, सो गिव मी, मैं 4 दिन बाद आऊँगा. See, this is irony in our country. And very importantly, coming to the metros and the bigger cities, the affluent class of patient often pay less and demand more. Agree? See, they go to a consultant. They pay 500, 1,000, 1,500, 2,000 rupees fees. But for a family physician, if you ask for 300 rupees, he will take 20 minutes for you. वहाँ पर 2 सवाल से तीसरा सवाल नहीं पूछ सकते, हमारे पास वो 20 मिनट से ज़्यादा लेगा. Am I right? So this is the irony of fact. What are the solution? Implement government-backed insurance scheme like Ayushman Bharat. Why? Be effectively utilizing family physicians. The Ayushman Bharat scheme can achieve its goal, very importantly, providing affordable, accessible, and quality health care to all citizens of India. So we will request government to kindly involve the family practice and the family physician in the Ayushman Bharat scheme. And Madam Finance Minister is going to present her financial budget on the 1st of February 2025. May I request from this platform कि मैडम हमें भी कुछ tax benefit दो. So introduce tax benefit to family physician, especially, I am talking very especially, practicing in a rural underserved area. This scheme can be introduced by the central government or this can be taken by the state government also. Professional isolation. Family physicians working in remote areas often face professional isolation. One of my friend practicing in Chikli, very remote area from Surat, he said, I have everything. I have a good practice, good revenue, good family life, good social life, but what I need is a professional isolation. In my place where I was practicing, there are only 2 MBBS doctors. But what can be the solution for this? We have a solution for this. Develop networking platforms, regional professional bodies for family physicians. I am very happy that this time FPI has given us a kind of a guideline कि अगर आप सूरत में कॉन्फ्रेंस करते हो तो make it a zonal conference. So this time we have a conference in the first week of February and we are going to invite all family physicians from Ankleshwar to Vapi, those who wish to join our conference without extra delegate fees. So we are trying to bring more and more allopathic general practitioners, family physicians within the purview of FAPI. 2 advantages. They will have an excellent clinical feast and we will have those family physicians are not within the covered or umbrella of FAPI. Second thing, use telemedicine and online CME programs as I said earlier. IMA, CGP and units of FAPI offer several CME programs useful for a family practitioner in day-to-day practice to update our clinical skills. Burnout, mental health issues. Combination of high patient loads, emotional demands. High patient load तो अभी season में इतना नहीं होता है, but emotional demands. And the administrative work leads to burnt out. अगर आप, if you will work for 10 hours a day, naturally you are going to have a kind of a mental exhaustion. See the solutions. Encourage work-life balance. Very important. I message to all my family physicians friends by limiting working hours and hiring a support staff. When I was inquiring my friend, he said, मेरे पास एक कंपाउंडर है, मैं खुश हूँ, मुझे दूसरे की जरूरत नहीं है. बट मैंने बोला जब वो बीमार होगा, वो नौकरी छोड़ के चला गया तो आप क्या करोगे? Everything you have to handle. So I request all my family physician friends that at least hire one more support staff. This may look not practical today, but down the line within 3-4 years you will say revenue भी बढ़ी है और comfort zone में मैं ज़्यादा practice कर रहा हूँ. Promote mental health. Yesterday we had an excellent on mental and holistic care. So promote mental health awareness, providing counseling service to healthcare professionals. We see many family physicians have a borderline depression, but they never come forward. But if you provide them a very logical and academic services, this can be possible. And very importantly, my friends, at least engage in one sports for fitness, relaxation and fellowship. Ever since I started table tennis since last 15 years, I have an excellent fellowship. जहाँ भी मैं खेलने जाता हूँ, यहाँ आपको कितने दोस्त मिले आप? We are all in a kind of a very relaxed mood. दोस्त मिलते हैं, गले मिलते हैं, बातें करते हैं. This is what you call fellowship. But if you engage in one of the sports, I tell all my friends that जिंदगी में दो चीज अगर हमें खुशी से जिंदगी जीनी है, तो either engage in one sports. This can be indoor, outdoor, whatever it may be. And engage कोई भी एक इंस्ट्रूमेंट सीखो. वो माउथ ऑर्गन भी हो सकता है, केसू भी हो सकता है और गाना गाओ. Singing will give you a good, absolutely relaxing thing. बाथरूम में गाना गाना अच्छी बात है, but try to sing. अभी तो काफी हमारे पास सुविधा है. Engage in one sport for that will give you fitness, relaxation, and importantly, fellowship. Competition for specialists and quakes. All you agree with me? Yes. Family physician face competition from specialists, unqualified practitioners, both in urban and rural areas. See, this is the irony of fact. Those who can't understand, मैं गुजराती में कहूँ, 70,000 આપો 10 મિનિટમાં નકલી ડિગ્રી લો, અમદાવાદમાં બને છે, સુરતમાં ગ્રાહક શોધાય છે. રાજ્યમાં 4,000 નકલી ડોક્ટર, જેમાં 1281 પ્રેક્ટિસ કરી રહ્યા છે, 27-19નું કોઈ ઠેકાણું નથી. Those my friends who can't understand Gujarati, the fact is the government of Gujarat has taken an initiative to combat the bogus doctor. सूरत में क्या हुआ? They arrested numerous bogus doctors. और वो जो डॉक्टर्स जहां प्रैक्टिस करते थे वहां से उनका जुलूस निकाला और लोग देखते ही रह गए कि ये बंदा जो 12वीं कक्षा पास नहीं है और उससे 10 साल से मैं इलाज करा रहा हूं. This is what we should do. Bring all more and more bogus doctors, and this is possible not for, by family physicians. We need a civic authority support, police authority support, and importantly, government help. But the solution is strengthen the legal framework to curb quackery, emphasize the role of family physician in preventive and holistic care to differentiate their services. Ever since we have started project for the senior citizens, बुजुर्गों का हम सफर, and we are just giving them how to lead and live a better quality of life. हर महीने हम 2 प्रोग्राम करते हैं, संगीत का प्रोग्राम भी करते हैं, and I am very happy to state that till date, my group, our group, my organization, Family Physician Association, we have addressed more than 30,000 senior citizens across the country. And not only Surat, there are different units of FPI are also going to, they have already started and some of them are going to start our program, Buzurgo Ka Hum Safar. That gives you a kind of a relaxation, happiness, not to me, but those senior citizens who really wish to update and upgrade their family life, their social life, their economy life after the retirement. Motivate family physicians to engage in adult vaccination, very importantly. Pediatric vaccine तो हमारे पास नहीं है. Yesterday we had an excellent discussion, very first lecture regarding adult vaccination, indulge in adult vaccination. This is where हम लोग क्या करते हैं, जब तक कोई चीज़ की हमें पता ही नहीं होता है तो मैं लेने को क्यों तैयार होगा? And when I speak to many senior citizens, they said हमें सिर्फ कोविड का adult vaccination खबर है, बाकी कुछ पता नहीं है. So first of all, make them aware. There is awareness should be there in the society, and then after awareness, more and more senior citizens, 60 plus, 65 plus, and 4 vaccinations, keep it in mind, pneumonia, influenza, hepatitis, Tdap, and Gardasil. ये 5 वैक्सीन की बात करो, बाकी तो हम सबको पता है. सिंग्रिक्स भी अच्छी वैक्सीन है, That is all very good. But इसकी अब बात करोगे ना, I tell you, you will definitely increase the OPD in your practice and ultimately you have a good revenue to earn. Low awareness of family medicine among patients. Patients often bypass family physician to directly consult specialist, leading to a very important word is a fragmented care. What we see a patient from head to toe. जो फैकल्टी है सब अच्छी है, दे आर ऑल सुपर स्पेशलिस्ट, बट दे फोकस टू दैट पर्टिकुलर स्पेशलिटी. हम अपनी लाइन सी द इम्पोर्टेंट आयरनी ऑफ फैक्ट कि जब भी हमें प्रैक्टिस करना शुरू करते हैं ना, तो अगर कोई पेशेंट डिफिकल्ट है कि चलो बड़े साहब को दिखा देते हैं, मतलब हमने अपनी जात को पहले से ही छोटे साथ समझ के रखा है. सो हम अपनी लाइन, उनकी लाइन छोटी करना नहीं चाहते, अपनी लाइन ठीक करना चाहता है. और मैं यही कहता चाहता हूं कि हम पंछी एक डाल के. Conduct awareness campaign highlighting the role of family physician, comprehensive and cost effective care. This is what we can do. See, we family physicians involved in a very limited social services. आप स्कूल में जाओगे तो सबसे ज्यादा आपको बोर्ड ऑफ डायरेक्टर्स में एजुकेशनलिस्ट सीए दिखाई देंगे, बट वी हार्डली फाइंड डॉक्टर्स इन्वॉल्विंग इन सोशल लाइफ. हम सोशल लाइफ जीते हैं, but for the society, we should frame a kind of a social network, not the social network of Facebook or Instagram. Go personally, motivate them that why my practice is so cost effective. Challenges with digital health integration, Pragnesh very rightly said, many family physicians find it difficult to adapt electronic medical records. But yesterday, Dr. Pragnesh Vasarajani said very rightly, that in the Clinical Establishment Act, this is going to be a mandatory. So, अभी से अगर आप नहीं सीखे तो सीख लो. Provide training programs to help family physicians use digital tools effectively. Smartphone सिर्फ WhatsApp, Instagram, Facebook नहीं है. इसके सिवा you can have so many good positive things which can give you a good learning devices. Offer subsidy or grant to adapting new healthcare technology. EMI दो, मुझे लैपटॉप लेना है, मैं धर्मपुर में प्रैक्टिस करता हूँ, EMI दो, मैं खरीदूंगा. Robust referral system is a comprehensive digital platform that streamlines patient care coordination across the healthcare providers. See, I say it always, HITCON ने मुझे काफ़ी कुछ सिखाया है. आर्टिफिशियल इंटेलिजेंस हमारी ज़िंदगी में आ चुकी है, कहाँ तक जाएगी हमें पता नहीं है. But if you attend this kind of conference, that will give you a very updated knowledge regarding the recent advances in digital technology. So in conclusion, I would like to say addressing these challenges requires a multi-level approach, not a singular, involving policymakers, medical associations, family physicians themselves. By improving infrastructure, training and public perception, family physician can be empowered to play even greater role in India's healthcare. Friend, this is an era of smart practice. And this is what I would like to say. This is a small video. Can you operate the video? Yeah. See, this is a small video. The guy on my left has accepted the challenges, and the guy on the right is just struggling to accept the challenges. This is an era of smart practice. See what will happen if you become smart. You परिवर्तन समाज का नियम है, और परिवर्तन को आप एक्सेप्ट कर लो तो क्या होता है? You have to address and accept those challenges. अगर देखो ये बंदा स्ट्रगल कर रहा है, देखो क्या हो रहा है. Now see. Now if you are smart enough, what can happen? This is what we call smart practice. Thank you. Thank you for inviting me for a very first family physician FFPI oration. Thank you so much.
Thank you, sir. A captivating talk that sparked many new ideas. Now I would request Dr. Ashish Patel, sir, to please honor Dr. Jayendra, sir. For the next session, I would like to invite Dr. Sadashiv Sir Gulbarga, Dr. Ramlal from Kolkata, Dr. Ketan Sir from Vadodara, and Dr. Gumant Mahindra Sir from Jamshedpur to chair the session. It is my honor to call Dr. Shomu Bora Sir on stage and explain about ECG, which make you alert. I would request the chairperson to introduce the esteemed speaker.
ECG alert, second.
Hello. I know all of you know Dr. Somu Bora, a consultant electrophysiologist, UN Mehta Institute of Cardiology and Research Center. He is visiting hospitals in Ahmedabad and Vadodara. He is the author of chapters in various books of ECG. I request Dr. Somu Bora to start.
A very good morning, the august audience. Thanks FPA to invite me here, especially Dr. Pragnesh for giving this ECG talk. Dr. Pragnesh has described that you need to be aware of basic things, get a good infrastructure. So let me put this way. How many of you have ECG machines in your clinic? How many of you don't have it? And why don't you have it? Is it the cost, or you don't know how to read, so you don't want to do it? So again, updating your knowledge. Right now the ECG machines are available very easily. 15,000 rupees, you can just upload it on your mobile and you can get a 12-lead ECG. Spandan, various Indian companies bring up these ECG machines that can be used in the periphery also. You don't need good infrastructure. You just have to have this small thing. You need to apply the ECG. They will upload it onto your smartphone directly. And if required, they will also give you a report within some time. So that is one. Second is knowledge that you have. Means you have been practicing for so many years. And the patients have more faith in you than any of the specialists put together. Even when I say that you have to go a procedure, they will call, no, you ring up my family physician and let me know whether it is right or not. So I have to talk to a family physician, take his approval for doing any procedure. So the faith that you have is unparalleled. We are just passers-by for one procedure or otherwise. But what you do is something which is commendable. And thirdly is updating your knowledge, learning new things. So a basic framework of knowledge is very important in any situation, and recognizing these small things is very important. And all the investigations put together is based on some clinical criteria. So if the patient has chest pain and the ECG is normal, I will still refer the patient. If the patient has bradycardia, you don't understand anything and the ECG shows bradycardia, I'll still refer a patient. So clinical knowledge is the basis of any investigation. Investigation will help you to become alert when to refer immediately or when to refer late. That is what I am here for. So starting my talk on this basis, what are the cardiac conditions wherein you need immediate attention, be alert, and these are any patient who has chest pain and ECG suggestive of ischemia, any patient who has bradycardia, and patient has ECG suggestive of a heart rate which is less than 50 or 60. If a patient has palpitations, giddiness, and the heart rate is beyond 150, and there are some miscellaneous conditions which I will talk to. So what is ischemia? And this is the most common complaint that a patient comes with, chest pain. Chest pain which is central, which is a dull aching, a patient who says that it is crushing sometimes, increasing on walking, but typical features of an unstable angina would be chest pain at rest, sweating, nausea, vomiting. If you have this and you take a ECG, generally it will be abnormal if the patient has an MI. So the features of any ECG during ischemia will be infarction, ischemia, or injury. So ischemia will be represented by T-wave inversions, injury will be by ST elevation or depression, and infarction by abnormal Q waves. And I hope that you have seen these ECGs quite often. So we'll go one by one, and I'll keep it interactive. So this is a patient with chest pain who has come to you. What do you think? Is it a alerting ECG or a non-alerting ECG? And what is the alert due to? Excellent. So is it a acute anterior wall MI and an old anterior wall MI? So if a patient has ongoing chest pain, that means something is going on. If the patient did not have chest pain, then my mind goes somewhere else. So if a patient has ongoing chest pain, the first thing I'll think is this is an anterior wall MI. And you need to refer immediately. Why? Because there are no Q waves. So if you see the ECG, there is significant ST elevation, but no abnormal Q waves. So ST elevation is in the anterior leads, and that suggests anterior wall MI, large area of infarct, and therefore it is a high risk. So you need to be alert to send the patient immediately, because it can be revascularized very easily. On the other hand, you have this patient. Now the ST elevation is not very high, but again there is no Q wave, but the ST elevation is in large area. 1N AVL also ST elevation is there. So any ST elevation in a larger area means more leads, 1 AVL, anterior, all the leads, or ST elevation which is more. These are the two high risk features where you need to be alert to send the patients immediately to a interventional or a center wherein you can have modern facilities like IABP and angiography. On the other hand, this patient who has chest pain, but it was 12 hours before, one day before, now is settled nearly and has come in a patient to say that I had some chest pain, I'm okay now. So what to do? So you can see here that there are Q waves, abnormal Q waves which have come. The ST elevation is still persisting. So persistent ST elevation can still occur with ischemia, still you need to refer, but these are patients where infarct has already developed. Patient with no pain and is coming to you, definitely you can wait, but if you have an ST elevation persisting, you can still send the patient immediately. So still a patient requires a referral immediately. What about this ECG? When you find a patient who has a simple monophasic QRS complex, these are the highest risk patients. Highest risk patients, ongoing chest pain, send the patient immediately. So recognizing the high risk patients is very important. So anterior wall MI, ST elevation persisting, absence of Q waves, these are treatable immediately rather than sending otherwise. Coming on to this patient wherein the patient has chest pain, but you find what? You have ST elevation or not? So you have ST elevation in leads 2-3 AVF rather than the anterior leads, and these patients are inferior wall MI. Inferior wall MI have lower risk as compared to anterior wall MI. The ST elevation in inferior leads means a smaller area, that is a smaller area of infarction denotes lower risk as compared to anterior wall MI. So when we see this anterior region, it's quite large as compared to the inferior region, and that is where you should recognize ST elevation in anterior leads, 1N AVL, higher risk, 2-3 AVF only, lower risk. Okay. A patient who presented with chest pain again, what do you think is the reason? Sorry? HCM patients, why should they have chest pain? So again I said clinical knowledge is very important. The first thing that you should understand is clinical knowledge. Clinical chest pain, you have deep T wave inversions which are symmetrical. HCM will have asymmetrical T wave inversions. Symmetrical T wave inversions, QT prolongation, all signs of ischemia. Again, chest pain with T wave inversions is high risk. Always think of ischemia rather than a LVH or electrolyte imbalance, which is also associated with these STT changes. Again, a patient with chest pain. Excellent. Why did you say that? ST depression. So ST elevation is high risk, ST depression is low risk conventionally, but if you have ST depression in most of the leads, you can see ST depression is there except in AVR and AVL where there is ST elevation. So if you have ST elevation in AVR and AVL, but ST depression in all other leads, these are very high risk, even higher risk than the ST elevation MIs, especially the anterior or inferior, because this denotes triple vessel disease or LMCA disease. So ST depression of more than 0.5 millimeters or multiple leads involved is high risk patient. So you need to be alert. Any patient with chest pain with ST depression also denotes high risk. Lastly, this patient with chest pain. Okay, so good. There are three differentials: early repolarization, pericarditis, and MI. So if you think that this patient doesn't have MI, now chest pain is there, but what kind of chest pain? Chest pain on inspiration, expiration. These are the classical features of pericarditis. So if you have that, think of pericarditis because ST elevation is there in all the leads. There is no reciprocal changes and there is PR elevation in AVR. So simple, and if you auscultate, there will be a pericardial rub. So clinical features and echo if you do, it will be normal. No RWMA. So ST elevation in multiple leads, but the patient is otherwise stable. Think of pericarditis also. So switching on to bradycardia, patient who presents with giddiness, patient who has exercise intolerance or breathlessness, there are only two causes of bradycardia, sick sinus syndrome or AV block. What is high risk? AV block or sick sinus? AV block. So you get a patient who has fatigue only. The patient comes to you with fatigue, patient is able to walk but gets fatigued. So you can see here the P waves are more than the QRS complexes, but the QRS complex is very regular. If your QRS complex is regular, P waves are lesser than QRS, basic fundamental, this is AV block. And this is a stable AV block. The patient is generally stable. You need to be alert, but the patient need not be referred immediately. Yes, the patient should be referred to a cardiac center for further evaluation. But however, if you get this kind of patients who have syncope, you can see here this is coming here, the PQRS is coming and suddenly there is only P wave, no QRS. Suddenly the QRS is gone. These are the patients who are at high risk of having syncope or sudden injury or sudden cardiac arrest. And these patients who have syncope associated with bradycardia are at high risk. So again, ECG feature of AV block with syncope is high risk. Okay, not only ECG features. So if a patient who has a history of syncope and has LBBB at baseline, you have an LBBB at baseline and history of syncope, think that intermittent AV block is going to happen in this patient. Rather than say nothing, you need an angiogram, they require an Holter. They require evaluation to see whether there is a presence of AV block or not. So you can have this kind of patient who has a straight line. Now many patients say that this is very high risk, but this is a patient who had a positive tilt table test. This is vasovagal syncope, a conditional syncope which occurs only on standing, and you see this very often on response to stress. This is not high risk. However, if you see the ECG, you will say put in a pacemaker. No, this requires only counseling. So remember the context in which the patient is having this ECG, right? This patient does not require a pacemaker. He needs counseling only. This is tachycardia when we go. The ECG alerts are patient who has a broad complex tachycardia in general have associated cardiac disease and is generally referred to be a VT. So if you have this kind of ECG wherein you have a broad complex regular rhythm and you can see the P waves are more than the QRS complexes, this is a ventricular tachycardia, and ventricular tachycardia is actually a high risk. So refer these patients. They may be associated with structural heart disease. Again, similarly, the incessant runs of tachycardia, these are at high risk. Intermittent tachycardia occurring, and this is a normal rhythm, intermittent tachycardia. So incessant tachycardia, broad complex rhythm require. Can you tell me what is this ECG? Who takes a ECG in fibrillation? You need to cardio it, right? 12 lead ECG in fibrillation is something unheard of. So recognizing the patient is unconscious rather than taking the ECG and start CPR is the most important thing. So ECGs like this should never come onto a stage. Polymorphic ventricular tachycardia, wherein there are short runs of polymorphic, so maybe or may not be associated with long QT syndrome, drug related. What is this ECG? Recognize these patterns. What is this ECG? Patient was referred to us for ventricular tachycardia, but this was artifact only. Because this is normal ECG, you cannot have a normal one lead and abnormal other leads. So recognizing that the patient was normal in this rhythm is very important. Right. This is one thing that we always say, fast, broad and irregular rhythm, WPWAF, fast, broad, irregular, that is FBI. Very fast rhythm, broad rhythm, irregular rhythm is AFWPW, which needs treatment by a EP study RF ablation. Lastly, we go on to this ST-QT interval prolongation with VPCs. So if you have a QT interval prolongation with PVCs, think of electrolyte abnormalities or drug adverse effects or ischemia. These are the three things. Based on history, you can get what the problem is. Even before you get a potassium level, I can say this is hypokalemia. So you can start treatment of hypokalemia immediately. Bradycardia with significant STT changes, hyperkalemia should be thought of. Calcium gluconate immediately can treat the patient, especially in the clinical setting where the patient has been on drugs or with renal dysfunction. Significant STT changes in LVH, which was already taken before. So significant STT changes signify LVH or ischemia, and in presence of QRS voltage which is high can signify hypertension, aortic stenosis or HCM. So refer these patients appropriately. I will not go into these rare abnormalities, but this QT interval, you can see T-wave alternance is very important. Lastly, remember sinus tachycardia with a patient who is hemodynamically unstable. Sinus tachycardia, hemodynamic unstable, think of a significant blood loss or pulmonary embolism, or patient is having acute GI problems. So all these things put together would alert you. So this patient had pulmonary embolism, and the last ECG would be STT changes along with pulses alternance. This was provided to me by a family physician who said something is abnormal. Something is abnormal. Something abnormal itself recognizes that you know what is a normal ECG, and that's very important. Normal ECG, if you recognize and something abnormal is there, refer these patients if they have symptoms. So this was large pericardial effusion tamponade. Okay. Thank you so much.
Thank you, sir.
एक-
Sir,
One
please
minute.
stay on the stage.
Thank you, Somu Bora sir. And this is why you are called the authority in the field of electrophysiology. Thank you.
Yeah. So,
as a family physician, when we are practicing, when we get a patient in the night, say around 11 o'clock with acute chest pain, what I am doing is right or wrong, I don't know. First, I send him for troponin test. What is your opinion about that?
So if you have chest pain within 1 hour, troponin will be negative. It takes time for the troponin to rise. So duration of chest pain, if it is more than 2 or 3 hours, then troponin has value. The first is his history and ECG. If you have an ongoing chest pain and the ECG is normal, and the patient came at an odd hour saying that he's uncomfortable, doing an ECG after half an hour or 10 minutes even can show ECG changes. So repeating a ECG at the interval, if the patient still has a symptom, is the most important test that you can say. A normal ECG doesn't rule out ischemia. That is what I said. Clinical history of chest pain, typical chest pain, and if you have a normal ECG, still 5% of ECGs can be normal during acute ischemia. Repeat a ECG will show an evolution. So keep the patient in house. If you think that it is gastritis, give treatment for that, sedate the patient, relieve his anxiety, and then repeat a ECG. If the ECG repeat is also okay, patient symptoms have decreased by your initial treatment, then maybe you can keep. But if the ECG shows new changes, then that is going to evolve.
The reason is we have seen good number of patients having normal ECG and raised troponin.
That is what I said. Repeat a ECG is very important. Troponin rise takes time. So history of 4 hours of chest pain, you do a troponin, and if it's positive, it is then definitely ACS. But ECG normal and troponin normal, then repeat a ECG rather than troponin. So troponin can be repeated after 4 hours then.
Thank you.
Okay.
See, at an outset, I would say one thing. How many of you have a Sanjeevani kit with you? What is Sanjeevani kit? This is related to, it is dispersible aspirin 150 milligram, atorvastatin 40 milligram, clopidogrel 75 milligram, 4 tablets. This is what we call emergency kit. And how many of you have it? I have it with me. Absolutely, I am so happy. But distribute freely from your clinic. This will save a life. ECG ke saath, if you just give a Sanjeevani kit, many a times, even on the roads, patient with the chest pain, you don't know the cause, give a Sanjeevani kit. And I'm sure sometimes or other, we will be able to save a life. Thank you. Thank you, sir.
I hope there are no further questions for Somu, sir. Thank you so much, sir. I would like to request the chairperson to honor Dr. Somu Bora, sir. For the next session, I would like to invite Dr. Kaushik Rana, sir, on stage and enlighten us on management of acute cerebrovascular events. And now, I request the chairperson to introduce sir.
Dear friends, I am extremely happy to introduce today's next speaker, Dr. Kaushik Rana. Dr. Kaushik Rana is associated with Zydus Hospitals, Vadodara, as consultant neurologist with a decade of extensive experience. He completed his graduation and post-graduation at Baroda Medical College. His career began as a senior resident in the Department of Baroda Medical College, followed by an assistant professorship at GMER's Gotri Medical College, Vadodara. He pursued DM specialization in neurology and honed his expertise as a senior resident in the neurology department at SMS Medical College, Jaipur. Thank you very much. With this, I present you Dr. Kaushik Rana.
First of all, I am thankful to Federation of Family FFPI, Dr. Pragnesh sir, and organizing team for inviting me as a speaker. Regarding today's topic, management of acute CVA, my focus will be mainly clinical, where we identification of acute stroke. Then what are the recent practices going on, then secondary prevention and primary prevention, what we can do at our level. why it is important to know about stroke? Because stroke is the second most leading cause of death in India. So, and 60% of the people of stroke, they end up with disability. As we know, theoretically, I'm not going to discuss many things. There are two types of stroke, is hemorrhagic stroke and ischemic stroke. My one question, whenever any patients present to you with hemiparesis or in whom you are suspecting stroke, so aspirin empirically can be given or not? Yes, that's my point. Because until unless we know what type of stroke, we should not give empirical treatment. Regarding risk factor, we all know cardiac and stroke, both the pathology is same, vascular etiology. So the risk factor, there are certain uncontrollable risk factor like as the age progress, the incidence of stroke, family history. Then some are controllable risk factor like blood pressure, hypertension, atrial fibrillation, hypercholesterolemia, smoking, diabetes, poor circulation, lack of physical activity. So the importance of risk factor is also there, so we can modify them to prevent the stroke. So the most important thing, how do I know if someone is having stroke? Because some patient, they come to you clinically, कैसे पता लगेगा कि पेशेंट में स्ट्रोक कब सस्पेक्ट करना है? सो whenever there is severe sudden onset of headache, patient comes with sudden onset of headache, then dizziness, some imbalance in walking, then sudden onset of unconsciousness, अचानक patient unconscious लेके आए, then visual disturbance, some patient they started developing sudden onset of loss of vision or some blurring of vision, then difficulty in talking, then sudden onset of confusion or problem understanding what is being said, that is aphasia. Sometimes patient develops Wernicke's aphasia, they talk irrelevantly and we may think of some psychiatric problem may occur. Then there is drooling of mouth, sudden deviation of face and weakness, as we know, paralysis. The importance of this slide is any sudden event, neurological symptoms which occur suddenly, then the first possible things or possible diagnosis is something happen in the brain. Most common reason is stroke. Then there are certain atypical stroke presentations like movement disorders. Stroke can present with movement disorders like acute hemiballismus, movement disorders, then sudden confusion, then hemi-neglect syndrome. If patient is having right parietal lobe stroke, then they may ignore their left side of the paralytic side. They just see on the right side of. So this kind of presentation can occur. Then loss of sensation, cortical blindness, as I told, sudden onset of vision loss. These all the common presentation of stroke. Then there is a mnemonic, be fast. I request all of you to to keep this slide in your waiting area, so that all the patients and the relatives, they can come to know, okay, what are the signs of stroke when they come to you and refer to some hospitals. Like B for balance, loss of balance, sudden onset of loss of balance. Then eyes, E for eyes, sudden onset of loss of vision. Then face, sudden onset of face drop. Then arm, sudden onset of weakness in the arm. Then speech difficulty. If anything occurs suddenly, if any of the symptoms, they are the signs, they are the symptoms of stroke. So, and it is a time to call ambulance and refer patients to higher center is needed. Then there are certain stroke mimickers. Stroke mimickers, there are so many conditions in which stroke-like presentations can occur. Most important is hypoglycemia, then seizure, migraine, some hemiplegic migraine patients may develop recurrent hemiparesis associated with headache, then toxic metabolic then brain tumors, conversion reaction, demyelination, syncope. So all these, there are so many, there are list of non-stroke conditions. I told my students to check one investigation, what is the most important investigation if any patient presents to you in your clinic, which investigation you do at your clinic level? Blood sugar, yes. However, if any neurological patient comes, whether it is a headache, seizure, weakness, just check blood sugar, because sometimes hypoglycemia can present as various symptoms. So it is a very treatable condition. Just hypoglycemia can detect with just blood sugar testing. You can give glucose solution and patients may become all right. So now you suspect a diagnosis of stroke. Now when to refer? Where to refer? There is concept of stroke-ready hospital. Why it is required to refer patients to a stroke-ready hospital, that I will discuss later. The hospital which has all the facilities, CT scan, MRI, at least CT scan should be there, then cath lab and proper ICU facility to manage stroke. Regarding imaging, which is the best imaging modality for acute stroke? Okay, yes. CT scan is enough. There is no need to do MRI for diagnosis of stroke. So this is a guideline given by American Heart Association. So non-contrast CT scan is equally efficient to diagnose stroke, to exclude intracerebral hemorrhage. Our main purpose is to exclude, to decide the type of stroke, whether it is hemorrhagic stroke or ischemic stroke. If it is diagnosed, then there are treatment guideline is there. The MRI, the role of MRI is in certain condition to rule out certain stroke mimickers. But for initiating treatment, CT scan is enough. So the other diagnostic tests, only assessment of blood glucose is required. No other test is required for management of stroke. So after referring patient, after doing CT scan, we can come to know various type of stroke. This is ischemic stroke, hemorrhagic stroke, there is hyperdensity in the CT scan, and this is subarachnoid hemorrhage. So by doing, as in cardiac patient, by doing ECG, by doing in neurology, by doing CT scan, we can come to know what types of stroke is this. Right? Then in MRI, there are various types of stroke. Depending upon the vessels involved, we can see various kind of presentation. Patient may have middle cerebral artery stroke, that the branch of middle cerebral artery, anterior, middle cerebral artery and posterior, and depending upon that, patient can present with various clinical syndrome. Like if patient is having main MCA block, then patient may have global aphasia or complete hemiplegia. If patient is having anterior MCA, then patient, if it is in a language dominant hemisphere, then patient may present with just Broca's aphasia. In posterior MCA territory stroke, patient may present with Wernicke's aphasia alone. Then cortical, sometimes some embolic stroke can occur, some cardioembolic stroke or atheroembolic stroke, then they can present with cortical MCA territory. Then small vessel disease, perforators, then PCA territory, posterior cerebral artery stroke. These kind of patients, they present with just isolated vision loss, no neurological, no other motor deficit, just isolated vision loss. Then sometimes ACA territory, anterior cerebral artery stroke, this kind of patient, they present with isolated leg weakness. Sometimes patient presents with just foot drop and they have a stroke. So depending upon the area involved, patient presentation is varied, and so it is very much important to think stroke in any neurological patient who present with sudden onset of the symptoms. Now, why it is important to refer the patient? Suppose this is a slide, this is middle cerebral artery which supplies this much area of the brain, and there is occlusion here. And in this slide, this is a time and volume of the infarct. And the black portion is the dead tissue. In the brain, it 4 seconds is required for oxygen, and 6 to 10 seconds is required for glucose. So if oxygen is delayed after 4 seconds, then the neuronal injury can started. So it is important to open these vessels. See, after 2 hours, as the time progress, the dead tissue is increased. This is after 24 hours. If we are not able to open the vessels, then this much tissue we are going to lose. And if this patient, they cannot walk or they develop permanent disability, lifelong disability, if we cannot open the middle cerebral artery timely. So regarding treatment, there are reperfusion therapy to open the vessels, IV thrombolysis, and second is mechanical thrombectomy. IV thrombolysis, the 2 agents are currently recommended: tissue plasminogen activator and tinectaplase. Both has equal efficacy. The advantage of tinectaplase is we can give it is in a bolus form, whereas this tissue plasminogen activator we have to give on infusion therapy. So it over a period of 1 hour, and this tinectaplase we can give just a bolus therapy. Both have equal efficacy in managing stroke. Then if patient is having large artery stroke, then we can offer mechanical thrombectomy. Means we can remove the clot by retrievable stent, or we can aspirate the clot. I will like to discuss one case. 69-year female, hypertension, diabetes. Just 10 days back, she underwent left hip replacement. Now she presented with acute onset of right-sided hemiplegia and aphasia of 2 hours duration. NIHS score 18. The score can be decided by clinical presentation only. And this is her MRI. Can you see hyperintensity? This is diffusion weighted image. This is flare image. These all are old changes, but we are more interested in this diffusion weighted image. In MRI, there is no hyperintense signal in this area. So it is a diffusion flare mismatch. And this is an ideal candidate for reperfusion therapy. If this patient is showing hyperintense signal in this area, so it is already infarct tissue, and patient may not benefit with reperfusion therapy. When this is MR angiogram, you see this is right side, this is middle cerebral artery and branch, and beyond this there is no flow. So it is a left MCA territory stroke. So now what thing to be done? दोनों में से क्या मतलब treatment option, whether to give IV thrombolysis or not, or directly patient should go for mechanical thrombectomy? Pardon? See, patient underwent hip replacement just 10 days back. So it is a contraindication for IV thrombolysis. Any surgery in previous 3 months, head injury, bleeding tendency, these all are contraindication for giving IV thrombolysis. So for ideal treatment for her will be mechanical thrombectomy. So in this patient we did mechanical thrombectomy. See this, can you appreciate the arrow? Beyond this there is no flow, and after removing the clot, the flow is established. And this is on day 3. The patient is having complete hemiplegia at the time of admission 0/5, or on the day 3 we can achieve or to mobilize. So if the vessels can, if we are not able to open the vessels, then patient may remain bedbound for the lifelong time. So these are the current guideline, practical guideline. If patient symptom onset, patient presence within 4.5 hours, Then if patient is eligible, there is no contraindication for IV thrombolysis, then we can give IV thrombolysis. Beyond 4.5 to 24 hours, it should not be given as per the guideline, but we can decide on case-to-case basis. If there is diffusion flare mismatch is there and patient is eligible, then we can also give. But it is in a rare case-to-case scenario. But if patient presents within 4.5 hours, then IV thrombolysis is the ideal treatment of choice. Beyond 24 hours, standard evaluation and care, matlab antiplatelet therapy, general nursing care and other supportive treatment. After that,
Sir, 2 minutes are there. Sir, Rana sir, 2 minutes.
okay, sir, just one. If large vessel occlusion is there, then we can go for mechanical thrombectomy. Regarding antiplatelet therapy, administration of aspirin, if patient underwent IV thrombolysis, then it should be started after 24 hours. If patient did not receive IV thrombolysis, then dual antiplatelet should be started as early as possible. Other therapeutic agents, they are not recommended to give. Only aspirin and clopidogrel is recommended to give. Regarding blood pressure management, if patient is entitled to less than 185 by 110 millimeter is the ideal treatment goal for the blood pressure if patient is planned for IV thrombolysis. When to reduce blood pressure acutely? In presence of heart failure, aortic dissection, preeclampsia or any coronary event, then we need to reduce blood pressure also. Now, after the stroke, secondary prevention is more important. Antithrombotic therapy, dual antiplatelet therapy, management of risk factor like hyperlipidemia. Then if patient is having large vessel occlusion like carotid stenosis, then we can offer patient to carotid endarterectomy, stenting. Then other risk factor management. Then educations, continuation of treatment, and what to do in emergency. Education of the family and family members should be there. Then this is for primary prevention. Before, how to prevent stroke. This guideline is given by American Heart Association for optimal brain health. Hypertension, blood pressure should be less than 120 by 80, fasting blood glucose less than 110, then cholesterol should be less than 200 milligram, non-smoking status, then moderate physical activity for more than 150 minutes and vigorous activity more than 75, body mass index less than 25, and healthy diet like fruits, vegetables, fish oil, then fiber-rich diet, low sodium diet, and avoid sugar sweetener, right? So, for concluding, in the stroke, prevention is better than the cure. So, at family physician's level, we need to modify the modifiable risk factor for management of the stroke. Then whenever stroke strike, act fast. We need only non-contrast CT scan to treat. And acute therapy is available and it is effective. And other supportive care should be there like blood pressure management, sugar management and general nursing care. And awareness about the complications and education about the secondary stroke prevention. So, stroke is not just treated by just only neurologist or some neurointerventionist. It is a stroke team, and it started with you, patient, neurologist, intensivist, neurointerventionist, and emergency specialist. Thank you.
Thank you, Thank you, Dr. Rana. You had a very excellent presentation. Now, if there are any questions, 1 or 2 questions, quick questions.
Sir, if patient is having a mass effect, then we can give. There are other strategy to reduce mass effect like mannitol, 3% normal saline. If patient is having severe mass effect and there is impending herniation, then decompression should be there. Otherwise, per se, just plain stroke without mass effect, there is no role of mannitol. Yeah. Sir, clinically we cannot differentiate. That's why my first question was there, whether to give empirical aspirin or not. CT scan is required because there is no clinical cue which can differentiate hemorrhagic and non-hemorrhagic stroke. No. As per the current guideline, there is no role of heparin in management of stroke. We can give for DVT prophylaxis only. Otherwise, for management purpose, there is no role of heparin. Madam, ticagrelor, it is, we can give for case-to-case basis as per the treatment guideline. It is not contraindicated. The current guideline is aspirin and clopidogrel for secondary stroke prevention. The acute management is only IV thrombolysis and mechanical thrombectomy. If patient is having a resistant to dual antiplatelet, like a patient is having recurrent stroke despite of taking aspirin, clopidogrel, then we can offer ticagrelor also. All the guideline is for general treatment guideline. We can modify the guideline according to case basis also. Sir, it can be Bell's palsy or it can be stroke. We need to differentiate between UMN, whether it is UMN facial paralysis or LMN facial paralysis. Usually LMN facial paralysis is complete half of the face, patient is having a Bell's phenomenon. And in UMN, like stroke, half of the face is usually involved. Upper face is spared in typically UMN facial palsy. So it is a neurology, basically it is a clinical, we need to diagnose first clinically whether patient is having stroke or not.
Any further questions for sir? Okay, thank you so much, sir. You presented your work with such enthusiasm. I request the chairperson to honor Dr. Kaushik Rana, sir. Thank you, chairpersons. You are requested to collect your token of honor from Point of Honor corner for family physicians. Now I would like Dr. Kaushik Rana, sir, to pick a coupon for lucky draw.
268.
नहीं नहीं भूल जाएगा
268.
ये स्लाइडर है सर और ये पॉइंटर है नहीं पॉइंटर ये रहा वो रेड दिखेगा ये पॉइंटर है दोनों हाथ में
297. 297. Third. 234.
317. 317.
317. Yes.
For the next session, I would like to invite Dr. Manhar sir from Rajkot, Dr. Bharat Shah from Vadodara, Dr. Alpa Shah from Vadodara, and Dr. Vinit Jagnane sir from Ranchi to chair the session. Now I would like to invite Dr. Purvesh sir on stage and elaborate about lifestyle, small changes, big impacts. And I request the chairperson to introduce the esteemed speaker.
Can you go ahead?
We have Dr. Purvesh with us, intensivist at Bhailal Hospital. Next three lectures are Brahma, Vishnu and Mahesh of medicine. We are having interesting lectures, one from diabetology, one from lifestyle and another from cardiology. So to begin with, we have Dr. Purvesh with us. He is senior consultant at Bhailal Amin Hospital, graduate from Ahmedabad and postgraduate also from the same college. Also he is fellow in critical care medicine from Leelavati Hospital, Bombay. And his areas of interest include sepsis, antibiotics, mechanical ventilation, and definitely need of the hour, communication with relatives. Vast experience of 20 years. He is teacher and runs courses in critical care medicine and has various publications to his credit. Over to Dr. Purvesh.
Thank you. Thank you for the introduction and invitation. And it is, very heartening to see such a large and enthusiastic audience on the Sunday morning. So without much ado, I'll move on. So I think for all of us, first thing we all need is good health. આપણે ગુજરાતીમાં કહીએ છીએ કે પહેલું સુખ તે જાતે નર્યા, બરાબર ને? સો એવરીબડી નીડ્સ ગુડ હેલ્થ just for, not for anything, but at least a good enjoyment in the life. કે ખાવાનું આપણે સારું ખાવું છે, ફરવું છે, everything depends on the good health and how good health we can achieve, right? During the times of COVID, we were bombarded with the questions like, how can I improve my immunity? How can I stay away from the COVID and other chronic diseases? And probably improving immunity, I think I'll answer that questions during and at the end of my lecture, but most likely we did not have answers, right? આપણે બધાએ બધું આપ્યું, ઝીંક આપી દીધું, વિટામિન સી આપી દીધું ને આમળા ખવડાવી દીધા ને સૂંઠ ખવડાવી દીધી, પણ immunity, it doesn't depend only on that probably, but yes, what can lead to good health? We all know that what is the definition of good health. It is not just a physical well-being, it is mental, emotional well-being also, and absence of disease. So what is it? Like if I say absence of disease is 0. If you are healthy, if you are having a good health, that is plus, and if you are having disease, then it is minus. So absence of disease is not the good health, right? And there are many factors like genetics, environment and lifestyle which affects our health. Now genetics is not in our hands, we cannot change that, right? Environment, I think to control that, pollution કેટલું કરવું, કે બાજુમાં મારે સાયકલ ચલાવવા માટે વોકવેઝ જોઈએ. So it is not in the, I think, purview of or the realm of this audience or this hall. આપણા હાથમાં એ બધી વસ્તુઓ નથી. So what is in our hand? In our hand, we can change our lifestyle, right? And believe me, all the lectures are for, not for us, probably for the patients, but this lecture, I think probably nahi, most certainly actually touches our lives. Not only yours, mine also. So what lifestyle changes we can make to improve our health will be the crux of today's talk. And let's begin with this, that most of the doctors enter medicine to cure the disease, right? From the first MBBS to the final MBBS, MD or post-graduation or super specialization, what we are taught is, most of the times, 90% of the time, is how to cure the disease. Prevention probably is one of the subjects out of 16 subjects in the MBBS, right? So PSM also is a part, but it is one of the 16 subjects, and we don't tend to concentrate much on that. But most of the patients, at least certain wise patients, not most in our country but world over, what do they need is that how to remain healthy and how not to contract disease at the first place, and that is in the stark contrast with our understanding or our interest, right? So most of the patients who come to your clinic will not come કે ભાઈ મને બ્લડ પ્રેશર ના થાય, ડાયાબિટીસ ના થાય, એના માટે હું શું કરું, બરાબર ને? પણ મારે આજે આ પ્રોબ્લેમ છે, આ પ્રોબ્લેમ છે, આ પ્રોબ્લેમ છે, અને વી આર નોટ actually overcoming that problem. Most of our OPDs are full with this. So preventive care involves various things. Today I am going to concentrate more on lifestyle changes, but immunization is one thing where there are certain diseases we have actually eradicated from the world, right? Smallpox is one example, polio is another example, at least we have eradicated now in India. Chemo prevention is like giving folic acid to prevent pregnant ladies, to prevent neural defects. But lifestyle changes, what are that? So mainly 5 lifestyle changes everybody talks about. We'll talk in little detail about that. So one is diet, healthy diet, then exercise, sleep, and then addictions like tobacco and alcohol to prevent that, right? What you need to do that, and everybody is clear by now that tobacco consumption in any form, whether is inhalation or oral chewing, is harmful, not in long run, in short run also, right? एक बार की पी लीधું, that is apart, but long run, short term, tobacco is harmful. Alcohol, યસ ઇટ ઇઝ ડિબેટેબલ. આપણી પાસે લોકો લખાઈ જાય છે કે મને કાર્ડિયક ડિસીઝ છે તો આલ્કોહોલ મારે પીવું જોઈએ, બટ ઇટ ઇઝ વેરી સ્પેસિફિક. 30 ml રેડ વાઇન thrice a week may be beneficial in patients who are having heart disease. So alcohol also is harmful, there is no doubt about that. I am going to talk about these 3 things: diet, exercise and sleep, how we can incorporate in our life, and what small changes we need to make in this part in our life to improve our health, right? So first goal of diet is to maintain the energy, right? And the next goal is health and disease free life. You can see the burden, total annual cost of poor diet related to various factors is at least $50 billion in USA. Indian data are still not there. And obesity related medical costs, so admission to the work life problems are to the tune of $150 billion per year. So it is very clear that we need to improve our diet. Obesity doesn't mean that you need to be overweight or obese. So obesity nowadays is defined as the BMI of more than 25. But if you are in the teens and you had the BMI of 18, 19, and by the time you reach 40, 50 and your BMI has increased to 25 or 26, you are not falling in the overweight or obese category, but still it increases your chances of contracting the lifestyle diseases. Lifestyle diseases means a non-communicable disease like diabetes, hypertension, coronary artery disease or cancer, right? So it is very important that we watch what we eat. We have to be very prudent about diet. So what are the impact factors? What affects our diet? First is taste preference, કે મને ગળ્યું બહુ ભાવે, મને બહુ તીખું ભાવે, all that is first thing. But what you need to watch is કે તીખું ગળ્યું નથી, એમાં શું content છે, that is very important. Cost and food availability, however hard we try, પણ આજના જમાનામાં if you ask a lower middle class person કે તું દિવસમાં 50% time fruit કે vegetable ખા, it is not going to happen because it is so costly, right? One apple costs around 50 rupees. Nobody, I mean in the lower middle class के worker class is going to afford that. Then there are certain religious and social norms, like if we would have been at home today morning, what we would eat? Rotli saag dal bhat, roti chapati dal chawal. What we'll eat today? Roti chapati dal chawal plus 3 starters plus some namkeen during the main course, then sweet, ice cream, and at the end of pan ke kahin. So what happens is not only we are increasing the consumption or calorie, but we are including some unhealthy stuff also. So these are certain things, and most important thing, not at least for us, but for young people and kids, is media and marketing forces. They are packaging and communicating unhealthy stuff in very smart way so that we consume it very rapidly in large amounts, like sugary drinks or irritated drinks is packaged so fast, like butter and all, pizzas, burger, all that advertisement is so, we are so much bombarded with that we eat all this out of our ignorance, right? So then there are some marketing gimmicks, like these are the types of diets if you follow, then probably you will stay disease free. But mind you, these are the just names, and there is no science behind that. High protein diet, low fat diet, low carb diet, anti-inflammatory organic diet, Mediterranean even is not associated with long-term prevention of the diseases. So keto diet and all that, I think you need not meet dietitian for the name of certain diets. What you need to do is try to avoid certain kind of food stuff and try to include the healthy food stuff more, like fats which are not so good. So you see here we eat this daily: butter, ghee, cheese. Even coconut oil, which is considered healthy, is not healthy because it contains large amount of saturated fats. What you need to include is unsaturated fat, right? Poly or mono is immaterial. And trans fat, again, all the bakery items, even milkshakes, fried food, all this contains trans fats. So what you need to do is, I don't tell you that you avoid all this, but at least have it in moderation. Once or twice a month, maximum you can have it, right? So try to avoid saturated and trans fat, and any packaged food nowadays you get has particular labeling about what kind of fat it contains, right? So butter tame lo ke cheese tame lo ke any cake, bakery item like cookies and all, if you buy that, try to have a look on the backside that what kind of fat I am consuming, what kind of carbohydrate even I am consuming, right? And unsaturated fats like in olive oil, canola, sunflower oil, corn oil, peanut oil is based, right? So that is again coming from the nuts and seeds, avocados, legumes. Wild rice again is very important. Wild rice is brown rice. White rice actually devoid of protein and minerals. Again, it has been told that eggs, fish, artificial sweeteners, sugary drinks, fruit juices, again these are the very important addition to our life. The artificial sweeteners like stevia or saccharin, all that thing are actually not shown any benefit even in the patients who are having diabetes. So it is not useful. Again, eggs, it is considered very healthy, but remember, not because of my religious preference, but it contains actually saturated fats and trans fats. So unhealthy and healthy fat, both it contains. You can very well relieve eggs from your duty of health by including more vegetables. Fish again is told that omega-3 fatty acid is very high in the fish oil, but harmful side effects like mercury over the chronic intake of fish also should be watched. So vegetarian food is actually based on various studies. I can put forward at least 25 studies which I have gone through, and it has suggested plant-based vegetarian diet is based in prevention of long-term problems like obesity, coronary artery disease, hypertension, type 2 diabetes and certain cancers, and based on all these all-cause mortalities also. So last slide on diet. Avoid red meats, unhealthy fats, sugar, sodium and alcohol. So remember the whites, sugar, salt, even milk with high fat content you should be watching for, and greater intake of fruit, vegetables, nuts and whole grains. So these includes whole grains means wheat, not maida. Rice is brown rice, not our routine rice, and then jowar, bajri, corn, ragi, all that things are excellent. So almost 50% content of vegetables and fruits in every portion when you eat. So be it breakfast, lunch or dinner, you should include this, and all the times when you eat roti, chapati, you should use whole grains. So replace that, right? So ultimately the choice comes between this palatable and non-palatable, and there is a counterintuitive thing. તમે હંમેશા જોશો કે when જે વસ્તુઓ તમને બહુ ભાવે ને એ હેલ્ધી નથી હોતી, અને જે બહુ ના ભાવે ને એ જ હેલ્ધી હોય. તમને ફ્રૂટ્સ અને વેજીટેબલ્સ પર રાખવામાં આવે ને, યુ વિલ નોટ બી એબલ ટુ લીવ. કેક ને બિસ્કિટ ને પેસ્ટ્રીઝ ને પિઝાઝ ને ઓલ દેટ તમે જિંદગી આખી સવાર બપોર સાંજ ખાઈ શકો. સો અલ્ટિમેટલી આ બધી વસ્તુઓ સેલ્ફ control for everything boils down to that, but with clear understanding that plant-based diet is the best, not only for our health but in general health. Carbon emissions ને આ બધું પણ એનાથી ઓછું થાય છે. So next is the physical activity. So what is the importance? The importance is આપણે routinely as a primary care physician don't screen patients for the physical activity or don't give advice on this, right? Stroke થઈ ગયો, okay. MI થઈ ગયો, okay. 6 week પછી તમે થોડુંક ચાલવાનું ચાલુ કરો. But before all these things happens, do we prescribe? No. Largely not, right? We don't ask them to all this, to do all these things, right? But if you advise them, then probability of them contracting a disease is going very low. And sedentary lifestyle means any kind of activity, just walking in the home, doing daily chores and all. Actually, if it is not done, it is more harmful than smoking, alcohol, hypertension and diabetes, right? So remember, આપણે અહીંયા બેઠા છે બધા, બરાબર છે, but if you sit for longer duration every day, it is more harmful than this addictions also, or having hypertension and diabetes. So what is the physical activity? it increases our energy expenditure and it helps by doing that. But exercise, what is the exercise and difference between physical activity? Exercise is plant structure and repetitive physical activity, right? So there are various types. Without getting into details about all this, you need to do the exercise. So aerobic exercise, strength exercise, balance exercise, mobility exercise, these are prescribed in various ways, and standard endurance training is walking, jogging. Traditional strength training is muscle training, and high intensity interval training is something when you don't have time, પણ 10 મિનિટ માટે તમારે એક્સરસાઇઝ કરવાની છે, so it will be just warm up and high intensity strength and jogging or running. So within 10-15 minutes you get the benefit of the long duration low intensity exercise. And then there are mixed strength and aerobic training. Yoga alone doesn't suffice. Yoga is just a dynamic flexibility training. You need to have aerobic or a strength training with that. And these are certain benefits of exercise like cardiovascular endurance, muscle strength, muscular endurance, mobility. Body composition also changes. Without losing weight, if you reduce the fat content of your body, again, a lot of diseases are prevented. And then agility, balance, coordination, power, reaction time, all these things also becomes better with the exercise. And if you see that when you become physically active, your risk of dying prematurely goes down, and exercise and smoking quitting also adds years to your life. If you combine exercise with cessation of smoking, at least you get 3 to 4 years of your life into that. So how do you do the exercise? This is very important slide you need to remember. Frequency, at least 3 to 4 days a week. But sometimes if you are not able to do, it has been described very well that even if you are having Saturday, Sunday off, if you do exercise 150 minutes in Saturday, Sunday, it is equally beneficial. But yes, you just need to build up slowly. પહેલા દિવસથી 150 મિનિટ એક્સરસાઇઝ કરી દો, then you become more prone to injury. So within say 2-3 months of time, you build up, you can do exercise on Saturday, Sunday only, and you will reap the similar amount of benefit, right? Intensity is moderate or greater. શાંતિથી લટાર મારવા નીકળી અને પાન ખાતા આવીએ, that is not the type of exercise we want, right?
2 minutes left, sir.
Yeah, I'll be completing that. And time, at least 150 minutes per day. Aerobic activity of choice, whatever you want to do, walk, run, jog, according to your body type and fitness, you can do. And stretching, warm up before and after exercise also helps. So it is very important to remember that when it comes to exercise, every minute counts. So how do we incorporate that into your lifestyle? કે મને સવારે અડધો કલાક, સાંજે બપોરે અડધો કલાક, પોણો કલાક ટાઈમ મળતો નથી. How can you do that? સવારે 5-7 મિનિટ, બપોરે 5-7 મિનિટ, સાંજે 5-7 મિનિટ, 10 મિનિટ, you can do that. I think it is not possible. આપણા ક્લિનિક પર જતા હોય, park your car 10 minutes away from your clinic and walk to the clinic. પાછા આવશો 20 મિનિટ થઈ જશે. And every day if you walk like that, 7 દિવસમાં 140 minutes. So I don't think it is very difficult. Have internet based applications or a group where actually you are encouraged to do the exercise. Last part of my talk is sleep. I don't think I need to elaborate much on that what are the positive effects and negative effects of the sleep, but we at least need 7 to 9 hours of sleep per day as an adult. And improve the sleep hygiene by not having cup of coffee at the night time, not doing the exercise just before the night time, otherwise sleep will be disturbed. Then blackout curtains, staying away from the screen like mobile, TV, even the e-books are actually going to affect your brain. So improve the sleep hygiene and take advice. Don't shy away from the taking advice if you are not able to sleep properly. So going to bed or going to sleep is difficult, or you wake up in the midnight, then you should take the advice. So sleep is a golden chain which ties health and our bodies together. So this is the thing that you need to do these 3 things better to prevent certain disease. Obviously staying away from the addictions also is very good, but how can you improve the compliance? I leave you with one thing, that there is a story. Charak and his शिष्यas were sitting, and a general public was there. There was an assembly, and Charak has given a lecture like me કે તમે આ બધું કરો અને you stay away from the diseases. And he has given 5, 7, 10 advices કે આ બધું કરશો, you will never have to contact your family doctor. સભા વિખરાઈ ગઈ અને દેન ઓલ ધ શિષ્યસ કેમ ટુ ચરક બેક એન્ડ પછી સર તમે આ શું કરી દીધું. તો હવે આવું બધું જો લોકો ફોલો કરી દેશે તો આપણી પાસે કોણ આવશે, વોટ વિલ બી અવર ઇમ્પોર્ટન્સ. એટલે આજનું લેક્ચરનું કન્ક્લુઝન આ છે કે આ બધું આપણે ફોલો કરીએ અથવા આપણા પેશન્ટ્સને કહીએ તો પેશન્ટ્સ આપણી પાસે આવશે કે નહીં આવે, બધા ડિસીઝ પ્રિવેન્ટ થઈ જશે. ચરક ઇઝ ગિવન ધ રાઇટ વેરી સાયલેન્ટ આન્સર કે મેં બધું કીધું છે પણ ફોલો કરવાવાળા લોકો નહીં નીકળે. બરાબર, એટલે આ બધું કરવું પેશન્ટ્સ માટે પણ ઇમ્પોર્ટન્ટ છે, આપણા માટે પણ ઇમ્પોર્ટન્ટ છે. પણ એક વસ્તુ સમજી રાખવાનું કે આ કરીશું એટલે ડાયાબિટીસ 100% નહીં થાય, હાઇપરટેન્શન નહીં થાય, કોરોનાઇટિસ નહીં થાય, નહીં. ઇટ રિડ્યુસીસ યોર ચાન્સ. બરાબર છે, સિટીમાં ફ્લડ આવી જ જાય ગમે ત્યારે ને પાણી કોઈ છોડી જ દે, COVID-19 આવી જ જાય, એ બધું થવાનું છે. બટ ઇફ યુ વોન્ટ ટુ બેલેન્સ યોર લાઈફ, વર્ક એન્ડ હેલ્થ, then you have to follow, you need to follow all these things, and there is no better way than to start having good diet and exercise. Thanks a lot for patience hearing. Any questions? Yes, it helps.
Any further questions? No? Okay. Thank you so much, sir. Your talk was eye-opening. Now I request the chairperson to honor Dr. Purvesh, sir.
પ્રેઝન્ટેશન પેલું પીપીટી આપી છે વોટ્સઅપ કરી દો
અહીંયા
ડૉક્ટર બંસી સાહેબ.
Okay.
Good morning all. I would like to invite Dr. Bansi Sabu for the next talk. Dr. Bansi Sabu is currently the president of IDF, that is International Diabetes Federation of Southeast Asia, past president of RSSDI India, leading diabetologist, a friend, philosopher and guide for family physician in the field of diabetes, and always available at at disposal at any point of time whenever we need him. So we are privileged to have Dr. Bansi Sabu with us today. He is going to talk about a very important topic about initiation of insulin, the inertia that we have, the fear that is there in our mind. Forget patience comes later. So Dr. Bansi Sabu will talk about this. Welcome, Dr. Sabu. All yours now.
Yes. So let me start by thanking Dr. Vachhajani and Family Physician Federation of India. But I think we are sitting here with more than 90 minutes, and as previous speaker talked very nicely, that more than 90 minutes sitting is as dangerous as smoking. So it's a time for stretchability, and let us get up and give a good stretchability to your body. That's the best thing which you can do. Thank you. The next thing which he told is that if you have an issue of sleep, I give you full liberty for next 15 minutes for nap also. So just don't worry, you can have a good sleep too. So the point which he made very clear that a diet which is very important, and it's a major reason for many of us also to have diabetes, and many of our patients who have also diabetes. But one thing what we have noticed in last 25 years of our practice, when I was a medical student or a registrar in a medical school, when we were running the diabetes clinic with only 3 medication which was available, insulin, sulfonylurea and metformin, our 80% of the patients were not able to get control. And the situation is not changed in last 25 years with hundreds of medication with their combination, with a lot of data which has been published in our country and all over the world, but still our 2/3 of our diabetic patients are not controlled. So I think somewhere we are missing the link. And I am not very big expert of internal medicine, as when I was a student of internal medicine, even I scored high, I could get some medal also. But then I realized to do so much internal medicine, I picked up only one subject, and it was much easier for me, and it was only diabetes. And while practicing what I found that any one of you might be practicing anything,
you will find 30% of your patients are diabetes. So when I started, it was 5%, and today almost 1/3 of your patients will be diabetes. So I mean, each and every family physician, or whether you are a consultant of a gynec branch or orthopedic branch, still you have to know more about the diabetes. What challenge which we have is insulinization. It's a inertia. It's a big inertia. And let me tell you, this inertia is not with the patients only. Even if someone is a doctor also become the patient, he also have the similar inertia. I always ask my patients that what's the purpose of treatment, When you have a patient in front of you, I think one thing which we should ask the patient, the caregiver and yourself both, all three of you, that what's the purpose of treatment? It's a good quality of life, the happiness which we want to give to the family, we want to give to the patient, and that question we should ask constantly. I mean, are we doing good for the patient? Are we doing good for the family? Or is it going to improve the quality of life for the patient? That's the only question you should have in your mind, whether you are treating your own brother or you are treating whoever of the city of your patient or someone who might be your, someone who is who of your city also. What I'm going to talk is delaying insulinization in our country, and it's not only in our country, it's all over the world. The UK, there is a National Health Service, and primarily all patients are treated by a primary care physicians. That's what type 2 diabetic patients. All patients who are type 1, all who develop complications, all who have some special issue, then they have to go to the hospital to see their diabetes department. So I mean, the diabetes, type 2 diabetes is a disease of a primary care physician. I mean, primary care physician, maybe a family physician, maybe MD medicine person also. It's a disease where he is your first point of contact, and that's what the disease is with primary care physician. There are a lot of hurdles to start insulin therapy. Diabetes prevalence is increasing all over the world. This is International Diabetic Federation data. I'm not talking more about it. Can I have this mic also so I can talk while talking also? But this data from India, the ICMR data, in diabetes study. It is a national study of diabetes, which is one of the biggest epidemiological study in our country. It's not working. I don't know. Yes, I think it will work. Yes. It's one of the biggest funded study from our country. I was the chief investigator from Gujarat, and what we found that in India, we have around 101 million people with diabetes. This is in 2023, we published this data. And what we have at present, 236 million persons with dysglycemia. It means adult population. This is, I'm talking of above the age of 18. And most of us are above the age of 45 or 50. If I say it's 50, probably we have 50% of us are either diabetes or impaired glucose tolerance. We will have in our lifetime dysglycemia, maybe 2/3 of us. Even for a mildest stress, for any hospitalization, we will have dysglycemia. And this is the data. Many of us will not have the diagnosis itself, but this is what the data which we have in our country. At present, only 1/3 of them are treated by insulin. They are given insulin after 10, 15 years of diabetes. Even a doctor, when they say that, yes, you need insulin, the first answer is denial. They don't want to take it. And the same is with 46% of the patients who are uncontrolled, they don't want to take it. Now I always say, why patient is not taking the insulin? I think he sees the face of a doctor. How confidently you are saying him whether you have to take or not to take. I am sure I was listening sir lecture in first talk, then when sir says that you have to go to the other doctor or you have to go and get admitted in the other hospital, patient will not say no, because you are saying him very confidently. So if the patient who sees how confidently you are saying, patient does not know. The doctor was showing hyperacute MI. You all were diagnosing that this is the acute myocardial infarction. And I'm sure if you see that ECG, you will say confidently that patient that you get admitted. Patient is saying, no, I can't because I have a family function. I have a marriage in the family. Someone is not well, or I came all alone. Nobody is there in the family to take care of me in hospital. But still patient get admitted because you are telling him with a confidence. Well, that does not happen when we are talking about the insulin therapy. We say, okay, you take it, then say, no, no, I don't want to take. Okay, let me try some other medication. And that sort of an answer will not allow your patient to take insulin injection. This is, let me talk about the patients. It's a simple, a garden variety of patient. Any patient who is coming to you with a triple drug oral anti-diabetic therapy, maybe 3, maybe 4, maybe some of these patients are on 5. But if a uncontrolled diabetes with a patient HbA1c of more than 8 or 8.5, probably he becomes the right candidate to start with insulin therapy. Nothing works. This is one very important slide which I want to give you. Suppose some patients say that, let me try the 3rd drug, let me try the 4th one, let me try the 5th one. The problem is in India we don't have the data of our own to publish it again, but this you see. If you have already a patient who is on 2 drugs, if you add the 3rd one, it is not going to decrease significantly HbA1c. It's hardly 0.5. If you add the 4th one, rather than increasing, sometime it increased the HbA1c. There will not be any benefit in next 3 months because patient was having already 9 HbA1c. You added one more, it may increase the HbA1c, it may not have any benefit to that particular patient. So this is the only way at that point of time you have to add the insulin. So this is very confusing sometimes. A patient wants to add one more drug. The doctor is also equally interested sometimes because who will spend so much time? Patient is interested to understand the insulin therapy, but because we don't have the time, that's again a challenge for our patients not to start. We all know about the complication. I need not to talk about all these complications because diabetes is a disease which you must have heard 100 times and 1,000 times, but we all know that it increases the complication in diabetic patients. But delaying intervention, if you are delaying something for anything, you know, even the justice when it is delayed, it means justice is not done, right? The same thing, anything which is delaying, it means that treatment is not done. If some patient comes with a acute MI, you have to treat it with that window period. There is no point of treating the patients after 3 days with the same therapy, thrombolytic therapy. It is not going to give any benefit to the patient. The same way, if you are not treating the patient at right point of time, the time period which he has not given the insulin injection or he has not been controlled for those 6 years, 8 years, going to increase the risk of complication in that particular patient. And that's very important. These are the therapeutic inertia. I am sure that we all have inertia. As I told you, even if we have the disease also, we also have the inertia. It's a distress which leads to, sometimes what happens, the first thing when someone is diagnosed, even with hypertension, diabetes, even for any disease, the first thing he comes with a distress. He feels that I should not have. Even many of us might have get admitted in hospital also for anything. The first thing which we feel that it should not have come to me, why I am getting it, and same type of feeling patient is also going to have. And that leads to inertia for him. The inertia is definitely with the physician related. What you can improve is the physician related inertia. It is we who are responsible for not giving, and there are hurdles. So my talk is how to make you more confident while writing insulin therapy. That's what the topic which is very important for us to have. Now the concern which we have, it may be hypoglycemia, but before that, many of us have already in our mind that patient will not accept it. And that is the reason you don't tell the patient with that much confidence. The conviction power will be only there once you are convinced yourself. If you are not convinced for that, you will not able to have a conviction power for patient also. The weight gain, hypoglycemia, and a poor quality of life. Sometimes patient says, who will give it? I don't have any family member who can give me, or I have to travel a lot of time and insulin to take along with me will be a real difficult. These are all logistic questions, and all logistic questions have an answer. It means these logistic questions cannot be only for you. There are many hundreds and thousands and millions of people around the world who have similar problems also, so you should have the solution for those questions too. These are the physician barrier too. The Dawn study results had shown that insulin therapy is delayed just because they feel when it is absolutely necessary at that time they want to give. Because people want to please the patient. We just want to give the medication which helps patient. No, we want to please sometime. Suppose patient is saying that 5 દિવસની દવાની જગ્યાએ 3 દિવસ લખે, હા સારું 3 દિવસ પછી જોઈ લઈશું, આપણે જોઈશું. So we are not here to please the patient. We are here to take care of the patient. For the health, for the happiness, we are here to give him a good quality of life. That should be our complete purpose of that. The physician barrier are there. Healthcare professionals are discouraged from initiating and intensifying therapy despite the poor control which they have. The suboptimal knowledge of the guidelines, difference between guidelines recommendation, changing targets and newer therapies, they all are the issues with many of us, because we don't want to sometimes stick with the newer guidelines too. The time and manpower, I think, is the biggest challenge. If you don't have a dedicated person with you who can teach, educate, or you don't have that much time, you would not like to put him on any newer therapy. And this is the reason sometimes we don't improve in our practice. Science is a constantly changing, and we have to improve over a period of time. I always say, we physician mean we are non-intervention specialists. I mean, someone may be a family physician, maybe a consultant physician, a diabetologist. We are actually poor as far as a new therapy is concerned to adopt it. Have you seen now today any surgeon who is saying that I don't do the laparoscopy? Because if you know that, if he is not going to do the laparoscopy cholecystectomy, a patient is not going to go and get open cholecystectomy. Am I right? So he has to go and learn that surgery. If someone is like an orthopedic surgeon, he has to go and learn that new technique. Otherwise, he will be out of the business. But that we don't do it. We feel that yes, हमारा काम तो चल रहा है ना, why to do all this nonsense, and let us do the same thing. So that's the reason we are not improving over a period of time. We are not adopting the new science and new technology in our field. And this is what every non-intervention, even for our interventional colleagues, if suppose somebody is gastroenterologist, even when he have done DM gastro before 50 years or 40 years, 30 years, there was hardly any intervention. But they learned. They learn to do the endoscopy, because otherwise they will not survive. They learn to do ERCP. When ERCP was not there in institute, they learn. They learn to do the angioplasty. They have to learn, otherwise they will be out of the business. But we could not accept, or we could not take it very positively for that. The physician education and training is very much required. As I told you, in last 25 years, with hundreds and thousands of CME you must be attending, and me also we are doing, but at the same time still we are not able to convince our patients, and our patients are still remaining with the HbA1c of more than 2/3. We talk about the stroke, we talk about the heart attack, we talk about many things, but the primary reason for that is this. Sometimes I feel so pity. A patient goes to a retina specialist regularly, paying him for 2 lakhs, 3 lakhs, 5 lakhs rupees, and not understanding the importance of a tight glycemic control. And that was the reason for him to develop all this, all this retina issue. He is not able to understand that problem is there. He is going continuously, regularly for a nephrologist for his renal failure, but he could not understand in last 20 years, he has not done. And what he could have done today, suppose you ask him, હવે તો તમારી kidney fail થઈ ગઈ, હવે તમે શું કરી શકો? Yes, we can teach him one more thing. Now you tell your daughter, your son, your brother, if they have diabetes, keep their tight control. If they don't have diabetes, check them, get them screened, get them here in my clinic. I will teach them how intensively we have to control. If they don't have, let us talk about the prevention of diabetes. So we have a lot of scope. As a family physician, it's not like that you don't have the practice. You have one patient, try to find out how 10 persons in the family. Not as a patient. We are not here to get more patients, but we are here to educate them. And we will get our business more running and running also. I mean, we have to educate, we have to teach them that yes, they don't have diabetes, let us try that they should not have diabetes in their lifetime. If they have diabetes, let us try early and aggressive control for them. If your father have developed a kidney failure, at least you should not develop kidney failure in your lifetime. That should be your message. That's what we should do trially. The solutions are definitely newer insulin are less hypoglycemic. There are hurdles from the patient side also. These are known as psychological insulin resistance. We know that insulin resistance is a concept, so we had put a new term for psychological, because patient does not want to take the insulin. PIR is very, very common. If you just ask your patient, many of them, they will say they don't want to take it, but once they will take it, they will have a better control. Once they will have better control, they will have better quality of life, and then they will follow you more regularly. It is ultimately a doctor prescription at that point of time. will not sufficiently satisfy patient. At that time, patient may be happy because you have agreed
Sir, last
whatever
2
the
minutes.
treatment which
Last
he
2
had
minutes.
given, but patient will be at the end, after few months, he will show only once the patient is very well controlled. These are some of the actions with insulin use behavior. These are the points which I just wanted to talk. The 3 key HCP action to facilitate insulin initiation were identified, helpful, were associated with more successful initiation and persistence. But I will not go with the details of all these things because point is, taking insulin makes it more difficult to fulfill my responsibility at work and home. And this is very commonly question which is asked by the patients. I am afraid of injecting myself. You can always teach the patient at the time of inside the clinic itself. Injecting insulin is painful. Now it is no more. With the 31 goes insulin needle which we are using, it's hardly any painful. How many of you have checked? I mean, you are not diabetic, not taking insulin. Have you tried insulin injection? I mean, just try it. It is not painful. It's not painful. Once you will try, then you will able to convince your patient more. I had used in 25 years multiple times just to tease the patient. In front of that I have taken. See, there is no pain. So I mean, take it and just give the patient example that there is no pain. Patient will be more confident if you do it yourself. Elevate the fear of hypoglycemia with the newer insulin, with the longer acting insulin. There is no hypoglycemia. There is a weight gain which is minimal because a weight gain is a control, or it can be controlled with a good control of sugar. There will be some weight gain, but now we have medication which can be done. Taking insulin means it is more flexible or less flexible. Because of the newer insulin, you can make flexible in the life. Like giving him a longer acting. A patient can take a Tresiba injection in afternoon and sometime even in evening time also. If he does not want to have, because ultra long acting insulin can be given also. And sometime before, I mean, maybe in another 3 months or 6 months when I will be talking, I will be giving once in a week. Icodec is coming. We will be giving only once in a week basal insulin. A time will come, a designer insulin will come when every day you have to take one shot and everything is fine for that also. There are stigmas for that, but patient does not want to take. Now, biggest stigma I have seen with the doctors. With so many meetings where we go, I am sure that 30-40% of them are diabetic. Out of them, you know that 1/3 of them has to be on insulin. So it means if I am seeing 200 people, there may be 50-60% must be diabetic, and out of them 5-6 must be taking insulin. Basal bolus. But I have never seen someone as a doctor who is taking lunch in a conference and taking insulin in front of everyone. I mean, that's sort of a stigma which we have. So why you have that stigma is there. Lipohypertrophy, if you know that it is a condition because constantly taking at the same place will lead to this problem. It's not the muscle which get increased, but it causes a lot of hypoglycemia and hyperglycemia too. There is a solution. Summarized to it's time to breathe insulin inertia. And I need not to talk more about it, but the only thing is convince yourself and then do convince your patient. For everything. It's not for the insulin therapy. Whether you are writing a person for a vaccine, first you have to get convinced yourself. If you will be convinced, then and then you will able to give the patient injection. If you are not taking the Shingrix injection for yourself, for your family, you will not able to give that herpes vaccine to your patient also. Because unless we are convinced, you will never able to convince your patients too. So for each and everything, whatever we are doing, and one thing we should always keep in our mind that we are doing good for our patient. That's the only purpose. Ethically, legally, by all means, we want to give him a good quality of life, and that we should have a question while treating the patient that what is your aim of the treatment?
Sir.
Will it give the treatment better or not?
Sir,
With this,
please.
thank you very much once again. I invite you for a national congress for a Diabetes India, which is going to be there in Ahmedabad from 13th to 16th of Feb. With this, once again, thank you very much. It's not available. It's no. So there is an insulin page was developed as the alternate route of insulin injection, but it is not available. The page pump is available, so that you can use the page pump, but insulin page is not available. Inhaled insulin is coming in month of September. It will be launched in India. Afrezza for India, it is the Cipla company is launching it. And from March onward, there will be a lot of activity for inhaled insulin. But it's a short-acting insulin injection, which can be taken like with long-acting and short-acting. So we'll be launching once in a week a longer-acting and a short-acting insulin. You can use the Afrezza also. We will see the results. I have done the clinical.
We will take the question answer during the lunch time.
Thank you, sir.
Thank you, sir.
Thank you so much, sir. It was a brilliant talk. Now I would request the chairperson to honor Dr. Bansi, sir.
I will request Dr. Abhay Dixit, Dr. Dhiren Mehta, please join us on stage. From this year, we have started Clinical Excellence Award by FFPI. Dr. Bansi sir, please be on the stage. So, we are giving away this honor to Dr. Bansi Sabu for the excellence in the field of diabetology from the FFPI. Dr. Bansi Sabu. Congratulations, sir.
For the next session, I would like to call Dr. Rakesh Joshi, sir, on stage and enlighten us on organ donation, way to continue to live forever. I would request Dr. Pragnesh, sir, to introduce.
Dr. Rakesh Joshi is a medical superintendent of the New Civil Hospital, Ahmedabad, and he works excellently in the organ donation. Thank you. Dr. Rakesh Joshi, please.
Thank you, Chairperson. I request the Chairperson to take their seats.
Now I request Dilip Deshmukh Dada to chair the session, please.
A huge round of applause for Dilip Deshmukh Dada and Dr. Pragnesh Shah, sir. Rakesh, sir, please continue.
Good morning. Hello. 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 Good morning, everyone. First, I would like to thank FFPI for inviting me to share our experience in organ donation. Myself, I am Dr. Rakesh Joshi. I am a medical superintendent at present at Civil Hospital, Ahmedabad. And by specialty, I am a pediatric surgeon, leading the head of the department in pediatric surgery, Civil Hospital, Ahmedabad. So, hello. Hello. Mic આપી દો ને. બરાબર? Okay. So today we are going to talk about organ donation, and you all must be aware about the situation of India so far the organ donation is concerned. Why we should spread such type of awareness in the society? The basic reason is the demand and supply ratio is highly altered. If you just go through the last year's data, the requirement of kidneys are in lakhs, like 3 to 4 lakhs kidneys are required for the patient to transplant. There is a long, huge waiting list, and what we get it like 20 to 25,000 kidneys in a year. The same way, thousands of livers are required, and few hundreds we are getting. You just imagine if one kidney or a part of liver can be donated by a family member, but it is not possible to give heart, lungs, pancreas, eyes, hands, and all these organs, which is the only source is brain-dead organ donation. So first and foremost thing is we must know what is the difference between organ donation and a body donation. I am getting call up frequently that કે દાદા હવે જવાનો ટાઈમ થઈ ગયો છે, તમારે કંઈ ઓર્ગન કાઢવા હોય તો કાઢી લેજો. That means society is not even aware about કે what is a full body donation and what do you mean by organ donation. So when a person is admitted in ICU, when patient is brain dead, all the central reflexes are absent, and in that case a particular apnea tests are done, and once it is declared brain dead, then you can say it is a brain dead. For us, the cardiac death we consider is a death. For a doctors, the scientific death is a brain death. So the period between scientific death and a cardiac death, I think that is a small window where a good organ can be donated, and it can be retrieved, and it can be donated to the person who is living with the end organ failure. આપણે એવું કહીશું કે they are on the verge of death if they are not given organ in time. Like you just imagine the family having a 3 times dialysis in a week, or a patient is like having a liver failure with ascites, edema, I mean grossly visible icterus and this and that. The person with heart and lungs failure needs a 50 liters of oxygen a minute at home. It is very difficult to manage. It is not only for the patient, but the whole family is suffering the issue. So, I mean, how we can start? Anyone can start the organ donation program in his hospital or in his setup. It is actually, you have to identify the person, the team members, and you will be surprised. Our team member is like, I have 5 medical officers, those who are working in civil hospital. We have like 5 PROs, we are working for this help, and 2 or 3 residents. Because you all are aware, the civil hospital, if I go through last year's data, we had like more than 11.8 lakhs OPD in a year. 56,000 surgeries. So I mean, if you go through this, workload in the hospital, it is very difficult for any faculty, any resident to work in this system for organ donation, and it has no monetary gain. It is just by heart. When you are involved with the program, only then you can, you can work for that. And the working pattern for this cause is many times 2 days, 3 days, 4 days. So once you detect somebody suspected brain dead, when you diagnose it, you convince the family, and then retrieval, and then transplantation. This whole process is so long that if you have a team, if you have identified the right people, and if you have designated a proper responsibility to the person, then and then only you can start this program. And exactly what I said, that we have a team of like 5 medical officers, 5 PROs, few residents, and that's how we started this program. And we, as a civil hospital, we got a license to retrieve the organs in mid-December 2020, around just before the peak of first COVID. The first organ donation happened on 27 December 2020. So it is now 4 years now. We identified the team. Initially, you don't believe, even in doctors, fraternity, it was very difficult to make them understand what is brain death, how we are going to declare. Many physicians, many people, they don't even accept that this is not done. If you go and if you take a round in the ICU, they will, તમારી સામે રીતે જોશે ને, like કયા લોકો આવી ગયા છે, and they will try to find out the organs only. So the whole mindset was very difficult, make them to understand what is the requirement, why we should do all this. We say that it's like any કોઈ cost નથી, invaluable organs, we are just losing them. We are not detecting brain death, we are not convincing the family, and everything goes in, સ્મશાનમાં બધું રાખ થઈ જશે. So we have to make aware the society, not only society, but each and every medical fraternity, paramedical people, and the society. So we started this, talking with the sisters, talking with the residents, talking with the faculty themselves. કે ICU માં રાઉન્ડ લઈએ ને પછી ખબર પડે કે this patient is, they are taking as a brain dead, then they will take a round and then they just skip that patient. So the family member will feel કે આપણે તો પતી ગયેલું છે, આપણે they are not going to manage us, આપણે અહીંયાથી લઈ જવાના છે કે organ આપી દેવાના છે. So that type of mentality, that type of behavior with the family, we should restrain that. We definitely should thank those people who are thinking about donation, because that is the only way of this retrieval of the organ which can help the unknown who is suffering end organ failure. So this is how we started convincing all the people, and the responsibilities was given to each and every team member. that being a medical fraternity, we started taking rounds in the ICUs, and those patients are having GCS less than 5. We are keeping them under observation, and once all the central reflexes are gone, then you can take that patient and start managing to have the same way like he's a brain dead. And then brain death management is a most difficult management. I can say even it is even, you know, the intensive or aggressive management is required to manage that patient, to take the patient for a apnea test. So a standard SOPs was created, and then the procedure was informed to each and everyone. So you take the round, you identify the brain dead, you manage that patient, and take that patient's vital parameters to that normal, that we can say it's a rule of 100. That the patient should have PO2 more than 100, blood pressure should be more than 100. In that sense, once you achieve that, pH should be in a normal range, electrolytes should be in the normal range. In this way, once that you achieve, after aggressive management, sometimes it requires 24 hours, 48 hours, and then you go for a apnea test. And first apnea test is done, and once there is a difference of CO2 more than 20 mm of Hg, like you disconnect the ventilator, take a sample, do the ABG, again after 10 minutes you take a sample, and that should not be respiratory movement or respiration, because we all know it is a centrally, this is a reflux. Once there is a carbon dioxide in the body increases, the level increases, it starts the brain centers to do a respiration. I mean, respiratory centers are stimulated, and if there is a no respiration, you take another sample after 10 minutes, and if the difference shows carbon dioxide collection more than 20 mm of Hg, we can say apnea test is positive. And it has to be done by, like, you know, 2 apnea tests has to be done like 6 hours apart. For an adult, for a child, it is like 12 hours apart. In both apnea tests are positive, then and then only you can say that patient is brain dead. To declare the brain dead, we should have a anesthetist, neurosurgeon, neurophysician, the consulting, physician, and any of two, they can declare the patient brain dead. And this is how apnea test is done. And after that, once you know that patient is brain dead, we need to talk to the families. सीधे सीधू આપણે વાત કરીએ, patient serious હોય, and then if you say organ આપવા છે, તો I think 100% will say no. Because everybody will feel that you are not doing anything and you are just asking for the organ. So it is a very slow process. You have to, you know, make rapport with the family. You have to talk to them like we are doing everything what is possible, and try to save that patient first. But even after doing all this, patient is deteriorating. It is not giving response, and now after second apnea, you can definitely say he's a brain dead. And then slowly, you know, grief counseling is done, where the role of NGOs like Dada comes, that sometimes the person who is treating the patient, they are biased about that, but if somebody, third person will come, then they will make them understand that this is the situation, and the best thing what you can do right now is, like, you can decide to give your organs, your loved one organs, and nowadays there is a database available. So on Notosite, if somebody has registered, that organ can be retrieved. Otherwise, in each and every condition, you have to take consent from the family members, and once they give consent, you have to, you know, just fill up the forms, like you have to fill up the form for the consent, and then you registered all this to the SOTO site, and then the organ allocation will start. If I'm talking about civil hospital, the liver, kidneys, pancreas, and heart nowadays, they are transplanted in the Medicity, and otherwise, if it is not available, the recipient is not available, it goes to the Gujarat, and then to the regional, and then to the national level. So this is how the process is, and it is an absolutely transparent procedure, that many times, you know, relative, they will feel that all these organs will be utilized by the relatives of superintendent or some leaders and this and that, but it is not like that. It is absolutely, once you enter an organ's name like kidney or a liver, then and then only this waiting list come. And waiting list is based on some points in certain disease and based on a severity of the disease. જેટલો રોગ ખરાબ રેસિપિયન્ટમાં એટલો એનો નંબર ઉપર. So that it's absolutely transparent system, and there are certain communities કે જે organ donation માં માનતા નથી. It is very difficult time, but slowly and steadily we are getting organs from those community which initially they are not able to do.
Last 2 minutes, please.
Okay. So I mean, that is how it is detected, and once it is detected, we decide the time, and for every time, just before taking patient to operation theatre, we do a prayer. Sarve Bhavantu Sukhina, like that we say in each and every prayer. I will say 175 organs. I must have been there around more than 160 prayers, irrespective of the time. 2 vage, 4 vage, 7 vage, whenever it is there, I am there, and that is just to, motivate your own team members because they are working since many hours. The same time you are thanking the family members who have decided to do this. So, I mean, this is the way the prayer is going on. These are the way we appreciate, even government of Gujarat and CM and health minister and secretaries, they are all, supporting the cause. And I mean, this is how it goes. And then for certain organs, you need like green corridors, like a heart and lung and pancreas, hands and like that. So far the journey of civil hospital, you can say that in a 4 years, 175 organ donation happens at Civil Hospital Ahmedabad. And you can say 568 organs were donated from the civil. Only single institute, 568 organs. And you can see the numbers, like 52 hearts, 360 kidneys, 30 lungs, 152 livers, 2 small bowel, 116 eyes, 6 hand, and a 10 pancreas. Just imagine about the hand. Raksha Bandhana divse behan rakhdi bandhe. It is something very different feeling altogether. The patient who are amputees and they are getting hand, they are wearing their jeans and they are driving, they are playing. They are even ત્યાં સુધી કે like આ વખતે ઇલેક્શનમાં વોટ પણ આપ્યો. All these things, that keeps you motivating to do something, a work like this. So this is, and many a times, એક અઠવાડિયામાં સળંગ 6 દિવસ ઓર્ગન થયા હોય, એક દિવસમાં 3 થયા હોય, એક દિવસમાં 2 થયા હોય. There are multiple incidences. That means our team is working hard and tirelessly and selflessly without any monetary gain. So I urge on this platform to all of you that make society aware, make your relatives aware, make your friends aware that we don't wish that anyone in your family become brain dead, either road traffic accident, brain surgery or hemorrhage. If such unfortunate events happen, please donate your organs, and it is highly required for those people who are suffering end organ failure. If we all do this, the waiting list will be, decreasing, and the live organ donation become less, or at the end we can abolish, because it is ultimately a major surgery. It is a supra major surgery to take out the liver from a normal person and then to transplant it. So the donor and recipient is okay, he is not well or he is suffering from the disease, but the donor is at risk of surgical complication. So we all should work for this, and if we can aware the society, more and more organ donation can happen, and that's how we can do this. We have created an area like Amar Kaksh, what we say. જેટલા લોકોએ ડોનેશન અત્યાર સુધી કર્યું છે ત્યાં પાછળ જોઈ શકો છો, આ બધાના ફોટોગ્રાફ્સ રાખેલા છે, અને like that area is so beautiful. તમે એકવાર once you enter in that area, there is a lots of positive vibes. So this is how. અને હવે તો એવું થાય છે કે એક વર્ષી થાય એટલે family members come and sit down there, right? So that's how it is done. Then we have released this handbook on organ donation. If you go through each and every page, any hospital or any institute can start this program. So I think in very short time it is very difficult to cover all these things, but thank you very much.
Thank you.
આપ બધા ફેમિલી ફિઝિશિયન્સ છો, એટલે ઘણું બધું આ વિષયમાં તમે પણ કામ કરી શકો. ભલે કોઈ ખૂણામાં તમારી હોસ્પિટલ કે તમારું કામ હશે, પણ આપ સૌને સ્વામીજી આવ્યા છે, સ્વામીજીનું સ્વાગત છે. સ્વામીજી વેલકમ. નમસ્તે. આપ સૌને પણ વિનંતી છે કે આપ ઓર્ગન ડોનેશન માટે પોતાનું નામ નેશનલ નોટોમાં રજીસ્ટર કરો. હું એક એની સાઇટ બોલું છું, જે લોકો લખી શકે એ લખી લેજો. નોટો, દેટ ઇઝ NOTTO સ્મોલ લેટર્સમાં .abdm.gov.in. ડૉક્ટર જોશી સાહેબે બહુ સરસ સિવિલ હોસ્પિટલની એમની ઓર્ગન ડોનેશનની જર્ની કહી છે, અને એક ઓર્ગન ડોનેશનના કારણે કેટલું ફરક પડી શકે છે એનું હું પોતે જ ઉદાહરણ છું. 10 જુલાઈ 2020ના દિવસે આઈ વોઝ ડિક્લેર્ડ ડેથ ઓન ટેબલ કેસ. ટુડે આઈ એમ લાઈફ ઓન ટેબલ. અને એકદમ મેડિકલ ટ્રીટમેન્ટ શું કામ કરી શકે એનું એક જીવંત હું પોતે જ ઉદાહરણ છું. ઓર્ગન ડોનેશનના કારણે એક બહુ જ સારું ક્વોલિટી લાઈફ સરસ આપણે જીવી શકીએ. મને લાગે છે સ્વામીજી આવે છે એટલે આપણે વધારે ટાઈમ એમને આપીએ, અને સ્વામીજીનું સ્વાગત કરું છું. Thank you, Dr. Joshi Sahib. Thank you.
Now I request Dilip Deshmukh Dada to felicitate Dr. Rakesh Joshi. I also request Swamiji to.
Now, during this 1.5 day of the conference, I got the maximum call for two speakers. One is Pujya Dr. Gyanamasa Swamiji and second Dr. Darshan Banker sir. People are asking what's new about that renal degenerations. What is this new things? And second, the people are asking, we are not registered for the conference, but still we can attend Swamiji's talk. So, this is in brief. We all know Dr. Gyanamasa Swamiji. He is a very renowned motivational speaker from the BAPS Sansthan. Without wasting much time, I directly request Dr. Gyanamasa Swamiji to start his motivational speech. Swamiji, please.
गुणातीतोऽक्षरं ब्रह्म भगवान् पुरुषोत्तमः जनो जानन्निदं सत्यं मुच्यते भवबन्धनात्. With prostrations at the divine feet of Bhagwan Swaminarayan and my Guru Hari, Param Pujya Pramukh Swami Maharaj, and my Pragat Guru Hari, Param Pujya Mahant Swami Maharaj, my heartiest namaskar, Jai Shri Krishna, Jai Shri Ram, Jai Swaminarayan, and a very good morning to all the family physicians, as I am told to come from across the states of our country to participate in this conference. Welcome all to the city of Vadodara. It's always nice to be in the midst of doctors, because seeing so many doctors at one time, even visually, if not seeing them for some treatment, betters your health by a few percentage. Seeing so many doctors just by your eyes, it betters your health, isn't it? Well, in 1987, I did get admission in the MP Shah Medical College in Jamnagar when I finished my standard 12th. But I opted for engineering because I wanted to go for my UPSC, for my public service exams. So engineering would give me more time to prepare for my public service exams. So knowing that, I didn't opt for a medical career. I opted for engineering. And while I was pursuing my engineering, my Guru Pramukh Swami Maharaj asked me to become a saint. He said, we can serve society better. So today I am in front of you as 32 years after my initiation as a saint. So where the topic shared with me today is think different, be different, and you succeed different. The first and the foremost thing, it's not about motivation, it's about understanding the basics of life. What is thinking different? When I talk to professionals, the first thinking different is, we are first human beings and then professionals. How many of you believe in this statement? Raise your hands. All of us. We are professionals, we are doctors, but first we are human beings and then professionals. One step ahead of that thinking different is, we are first spiritual entities and then human beings. Because we are souls and we are not this human body. As they say that, we believe that we are human beings on a short journey upon this earth now. We are actually spiritual entities on a small, short human journey upon this earth. So the first thinking different is believing yourself more as a human being than as a professional. Professional career or professionalism is part of human life, part of long, enriched human life. This concept basically cleared in our hearts and minds gives us new avenues in life, gives us the right perspectives in life. In any profession, there are thousands. There will be thousands. There were thousands. It will go on. Satisfaction and peace comes by believing yourself to be a human being first and then a professional. Human value system counts more in life and it adds to professional value system. We need to train our minds, raise our consciousness for that. A scientific journal by the name Medicine and Health in London. You might all be well aware of this science journal. The name of this journal is Medicine and Health. Publishes from London. It once reported a happening that two young friends, they checked inside the hotel, both occupied different rooms. One of the rooms was such that a cholera patient died a few days back in that room. Another room was such, which was a normal one. They spent the nights in the morning just for an experiment. The room that was normal one, that occupant was told that this was the room where a cholera patient died a few days back. And in the actual room where the cholera patient had died, the new occupant, the recent occupant wasn't told anything. By evening time, the occupant of the normal room, but he was told that a cholera patient had died, he actually caught cholera. He started vomiting by noontime. By evening time, he had vomited too much. Because his mind was constantly telling him that this was the room where a cholera patient died a few days back. And that adjoining room where actually the patient had died, that occupant was normal because he was not told that there was a cholera patient here. See the weakness of the human mind. Thinking different is making our minds strong and healthy to believe that situations and people should not affect me. My thoughts, my feelings, my generation of my conscience only affects me. This is the first thinking different so that you become different and succeed different in terms of satisfaction and peace. Success is not just like, you had a small clinic and then you jointly developed 3 doctors coming together to make a big hospital, and then you had a lot of patients standing in the queue and you are so much busy right from 6 in the morning to 10 at night. People have these definitions of success. If this were the definitions of success, many animals work more hours than us. More work is more success is an absolutely idiot definition of success. Professionals, they believe that more work is more success. No, donkeys, they work 12 hours a day. More work is not more success. If that success generates satisfaction and peace in you, only then it is success. Success should generate satisfaction and peace. More work generates more thirst, it is not success. More work generates more hunger, it is not success. Success should generate satisfaction and peace in life. So by this example which I started from the journal, medicine and health, it actually gives us the perspective that we need to train our minds, make our minds strong, to allow external situations, external happenings to affect us is the biggest weakness of a human mind. So we need to raise our consciousness. Raising our consciousness that can help us is thinking different, and then by a raised consciousness you become different. And then you succeed different in terms of satisfaction and peace. So first important aspect is that. Dr. APJ Abdul Kalam, way back in 1957, he went to Dehradun to appear in an interview and an exam to become a pilot. He ranked 9th in the results of that exam, and only 8 people were to be selected. Years later, he writes this incident. So he felt a bit depressed and dejected, and anyone would be. When he left Rameshwaram and was coming to Dehradun for these exams, he met a saint who had told him that when you are going to Dehradun, if you can manage time, definitely take a dip in the Holy Ganga and visit a nearby ashram. So he said, okay, chapter 1 is over, I appeared for the exams, now let me go for chapter 2 and chapter 3. So he took a dip in the Holy Ganga. And then he visited the Shivananda ashram at Haridwar, where a saint saw him. The saint could recognize. This whole incident is written, what I'm narrating now is word to word by Dr. APJ Abdul Kalam. He said, the saint from my face could recognize that I'm feeling a bit sad, I'm worried about something. So the saint called Kalam Sahab and said, are you worried about something? So yes, I didn't qualify for my exams and I wanted to always become a pilot and I failed the exams. The saint told him a few words. Dr. Kalam writes those words as it was said by that saint. First thing, the saint told Kalam that believe that God did not want you to become a pilot. First, see, this is called acceptance and making it a purpose of life. God did not want you to become a pilot. If at all God wanted you, you would have become a pilot. You tried your best, but you could not become. We tried our best for a different branch. Maybe. Some of you sitting here. Not all. You tried for a different branch, but you could not. Fine. Part of life. God did not want you to become a pilot. So accept God's wish for cooling down from within. Second, he said, forget the failures of life. And third, he said, believe that God wants something better from you, not something else from you. Something better from you. This is raising your consciousness. Kalam writes, yes, decades later I could believe these words practically in my life that God wanted something better out of me. If I would have become a pilot, I would have flown planes. Now I made something that could fly above the planes. I made rockets. We need to raise our consciousness. That is thinking different. Otherwise, routine life is there. आप डॉक्टर्स हो, सुबह में जाते हो क्लिनिक पे, हॉस्पिटल में अपना काम करते हो, पेशेंट्स को अटेंड करते हो, फाइन. रूटीन वर्क सब करते हैं. We need to make our mind strong and raise our consciousness that situations and happenings and people around us should not affect us negatively. That is the first raising of the consciousness. And second, the ultimate raising of the consciousness, God has designed something better for me if I did not get this thing. Only then you'll be able to remain in good spirits. Yes or no? Only then you'll be able to control your emotions and be in good spirits. Otherwise, there will be 10 happenings every day that can demoralize you. Even a not so proper good morning from somebody you wish can demoralize you. Not so proper good morning. यार मैंने बॉस को गुड मॉर्निंग कहा, उन्होंने ठीक ढंग से गुड मॉर्निंग नहीं. अब ठीक ढंग तो तेरी डेफिनेशन है. Raising our consciousness means not allowing situations and happenings and people around us to affect us negatively. Positively, they're fine, we accept it. Our Guru Pramukh Swami Maharaj, who created this BAPS organization, I come from the BAPS Swaminarayan Sanstha. We are one of the largest organizations in the world with a permanent seat in the United Nations as an NGO. We run 1,800 hospitals, hostels, schools, colleges, community centers, Sanskar Kendras, Mari Mandirs, Mandirs and Akshardham in 60 countries of the world. And we 1,200 saints are directly involved in the administration, management and the HR of all these institutes. So we know things. It is not that a couple of things that I have read in the book and I have come to talk to you. I am a saint since 32 years, finishing my engineering way back in 1991. So I know both the worlds. From that, what our topic is thinking different is try to raise the bar of your positive consciousness so that not only you remain in a spirited way of life, but you can affect positively the atmosphere and the people around you and become a shield for people not to get them affected by negativity around them. See, biggest success in life? To become a multimillionaire? No. Biggest success in life to be famous and getting so many awards? No. Biggest achievement or biggest success in life is having so many chain of hospitals? Now give me a yes or no. But I'm confident that when I put forward now, what I'll speak now as a definition of success, you will 100% agree with me. Definition of success is that a person who can live in a positive state of mind 24/7, 365, 80 of his life. 24/7 is 24 hours and 7 days of the week, 365 is 365 days of the year, and 80 is 80 years of your life. So my formula is 24/7 by 365 by 80. If you can remain in a positive state of mind, biggest success of life. How many believe in this definition of success? All of us. That is raising your consciousness. That is living in that state of mind. Pramukh Swami Maharaj, who created this BAPS to this level, as I said, we run 1,800 units. इसमें से बहुत कई सारे, they are world famous, like the Swaminarayan Akshardham at Robbinsville, New Jersey, America, the largest Hindu mandir in the Western Hemisphere, and the recently, just about 10 months back, the BAPS Swaminarayan Hindu Mandir in Abu Dhabi. You might have seen many videos of it. To come up with such projects on those lands, in these times, on those lands and in these times, is not an ordinary achievement. This foundation was laid by Pramukh Swami Maharaj. Building upon that foundation was today Mahant Swami Maharaj, our present Guru. In 1974, way back 50 years, Pramukh Swami Maharaj flew from Mumbai to Nairobi for his Dharma Yatra there in Africa. Due to some political disturbances and some political misunderstandings, it was announced when the plane came to the news after landing and after taxiing to the news, announcement was made that Pramukh Swami Maharaj and his group should not deplane. They are supposed to go back. The government of Kenya doesn't grant them permission to put their foot on the land of Kenya. Political disturbances, many misunderstandings, whatever. Here in Bombay, he was given a grand farewell. And now by the same plane, he was asked to return. चेहरा मुरझा जाता है, हाँ या ना? एनर्जी लेवल ड्रेन हो जाता है, हाँ या ना? Anybody. प्रमुख स्वामी महाराज के चेहरे पे लकीर फरी नहीं. Those saints who had accompanied him, they are the first hand witness of this. स्थिर रहे, स्वस्थ थे, वापस आए. When he was flying back by the same plane, somebody or one of the leading saints, he said, Swamiji, can you write the first page of my diary? Because he had brought a diary with him to note down all the, divine memories. પ્રમુખ સ્વામી મહારાજ wrote in Gujarati, આપણે પોતાની જાતને આત્મા અક્ષર માનીએ તો માન અપમાન શું છે અને આવું જાવું શું છે. What a state of mind. What a raising of your consciousness. That if you believe that I am the soul and not this human body, where are insults and awards or felicitations? And where is going and where is coming? Next day was in the morning when everybody saw, oh, Swami came here back. Why? Swami said, traditional Gujarati માં આનંદથી બોલ્યા કે હીરો ગોગેજી આવ્યો. For himself he could speak this. Slightest hesitation, no. Slightest ounce of depression or stress, no. What would people think of him? No. The biggest disease of the 21st century is, what would people think of me? આપણે એક સામાન્ય ટી શર્ટ ખરીદવા જઈએ ને તો પહેલો વિચાર શું આવે, આમાં હું કેવો લાગીશ? What nonsense. When we go to purchase our clothes, the first thought comes to our mind is, how would I look in this? Isn't this? This is the biggest wrong attitude, so you don't achieve stability of mind and raise your consciousness. You should just think, did I like this t-shirt? Yes. Am I paying for it? Yes. Enjoy it. You liked that, you are paying for that, then why are you waiting for external validation? And if somebody says that this doesn't go well with your skin tone, then you must tell, it went well with my wish and my choice. That is called stability of mind. Here we need to think different. No external validation. કોઈ આપણને કે તમે સારા મોટા ડોક્ટર છે ની અપેક્ષા શું કામ રાખવાની? Am I doing my work properly? Yes. Am I doing it honestly? Yes. Am I fully with the well-being of my patient? Fine. Then it's okay. We need to raise our consciousness for the stability of our mind, and that makes you a different person in terms of success, and that success is satisfaction and peace. If you have won the whole world, as a doctor, if you get awards and accolades from 50 countries of the world, but if you are not enjoying satisfaction and peace within, let me tell you in clear language, what the hell did you do on this earth? Satisfaction and peace is success. That is how the topic of this talk is, succeed differently. Money-wise, there are millions of successful people. Fame-wise, millions of successful people. Awards and recognition, millions of successful people. Are you successful from within, enjoying satisfaction and peace in life? That is real success. न्यूयॉर्क में डॉक्टर्स की मीट थी. कोई डॉक्टर आए, किसी ने उनके कान में कहा, रीडर्स डाइजेस्ट में ये प्रसंग मैंने पढ़ा था. I'm told to mix a bit of English and Hindi for the benefit of everybody. Somebody went near to the doctor और कान में जाके कहा कि you look like a monkey. इतने डिस्टर्ब हो गए, घर जाके उन्होंने आत्महत्या कर ली. This was Reader's Digest report. That is a story in Reader's Digest, years back. तुम प्रोफेशनल बने, प्रैक्टिस करते हैं, इयर्स का एक्सपीरियंस है, लेकिन माइंड में स्टेबिलिटी नहीं है, डिस्टर्ब हो जाते हैं, वी हैव नॉट रेज्ड आवर कॉन्शियसनेस, देन वी आर अ फेलियर. As you raise your degrees, raise your experience, raise your bank accounts, raise your fame, but it should be packed within raising of your consciousness. It is as simple as that. Second aspect of thinking different. First aspect क्या था? Raise your consciousness and stabilize your mind. Second important aspect of thinking different, being different and succeeding different is don't compete. Cooperate or contribute, but don't compete. मेरा बैचमेट था, हम मेडिकल कॉलेज में साथ में पढ़ते थे, उसकी तो इतनी बड़ी हॉस्पिटल बन गई और मैं कोई गवर्नमेंट हॉस्पिटल में जॉब कर रहा हूं. Am I talking something very fundamental? Grassroots. This thought has the power to kill you. मानते हो? Do you believe that this thought has the power to kill you? This thought has the power to give you 24/7, 365, 80 disturbance. Even after performing well, even after patients folding hands at you, साहब, thank you very much, आपने बहुत अच्छा कर दिया. Their relatives, their family members telling you, साहब, आपने तो हमारे family member को नया जीवन दे दिया. इतना प्रेम पेशेंट्स का मिलता हो, आपके वर्क से आपको सेटिस्फेक्शन हो कि चलो मैं अच्छा काम करता हूं, फिर भी गैलरी में आके वो बड़ी हॉस्पिटल देखी बैचमेट की, and disturbance starts. So my second point in thinking different is, he is he, I am I. वो अपने प्रारब्ध का, अपने मेहनत का और अपने पे हुई भगवान की कृपा का फल वो ले रहा है. मेरे प्रारब्ध का, मेरी मेहनत का और मेरे पे हुई भगवान की कृपा का फल मैं भुगत रहा हूं. He is he, I am I. Separate yourself from competition. Thought number 2. Be in the cooperative mode and contributing mode. मैंने आपको 3 C बताए. Competition, cooperation and contribution. Competition निकाल देना है, cooperation and contribution. तो आनंद आएगा. That is peace and success. वरना स्ट्रेस, एंड ये तो रेट रेस है. इंग्लैंड में बहुत बड़ी ये इंश्योरेंस कंपनी है प्रूडेंशियल, उन्होंने सर्वे किया जस्ट अबाउट 1 year बैक. 6 out of 10 Britons, they have come to know, they have actually realized and experienced that, my God, in this competitive world, it's a rat race. They are leaving their lucrative jobs in the city of London and retreating to smaller towns with 25% pay, because they have come to know एक सिद्धांत. क्या? वो स्टोरी पढ़ के मैंने ये सिद्धांत एक लाइन में लिखा. In this competitive world, it's a rat race, and even if you win the race, you are still a rat. Even if you win that race, you are still a rat. क्योंकि एक रेस आपने जीती, सेकंड रेस चालू हो जाएगी. हाँ या ना? बहुत अच्छी हॉस्पिटल बड़ौदा में बनाई, नाउ अहमदाबाद सर करना है. फिर साउथ में देखता है सूरत सर करना है, मर जाएगा. કેમ ભૂત સાહેબ પાછળ જોયો છો? स्पर्धा में नहीं. प्रमुख स्वामी महाराज ने इतने बड़े स्मारक बने. दिल्ली अक्षरधाम आप सभी ने देखा होगा. रेज योर हैंड्स. हाउ यू बीन टू स्वामी अक्षरधाम दिल्ली? उसके उद्घाटन समारोह में on 110 acres of land on the banks of Yamuna, Delhi, just in 5 years, 8 lakh cubic feet of carved stone का प्रोजेक्ट पूरा किया. And that too 20 years back, in the year 2005. प्रमुख स्वामी महाराज उद्घाटन समारोह में बोले. प्रधानमंत्री मनमोहन सिंह बाजू में बैठे थे, राष्ट्रपति श्री अब्दुल कलाम साहब बाजू में बैठे थे, अपोजिशन लीडर इन द पार्लियामेंट LK अडवाणी जी बाजू में बैठे थे, लेफ्टिनेंट गवर्नर ऑफ दिल्ली बैठे थे, हुज ऑफ इंडिया बैठे थे. 160 कंट्रीज में लाइव टेलीकास्ट चल रहा था. हृदय के भाव से प्रमुख स्वामी महाराज बोले. उनके चेहरे पे उनका भाव उस वक्त दिखता था कि जो वे बोल रहे हैं, व्हाटएवर ही स्पीकिंग नाउ, his feelings, his emotions were reflecting on his face. क्या बोले प्रमुख स्वामी महाराज कि ये स्वामीनारायण अक्षरधाम, क्योंकि बहुत लोगों ने तब तक तो ताज के साथ कंपैरिजन कर दी थी अक्षरधाम की। प्रमुख स्वामी महाराज पहला ही वाक्य बोले कि ये स्वामीनारायण अक्षरधाम हमने किसी के साथ स्पर्धा के लिए नहीं बनाया। वी हैव नॉट क्रिएटेड दिस टू बी इन कंपटीशन विथ एनीबॉडी। दूसरी बात बोले, हमने भगवान स्वामीनारायण के प्रति हमारी भक्ति है और हमारे गुरु योगी जी महाराज का संकल्प था कि दिल्ली में यमुना नदी के किनारे एक भगवान स्वामीनारायण और भारतीय संस्कृति का स्मारक बनाना है। तो हमारे गुरु की आज्ञा थी, वचन थे, हमने ये बनाया। और तीसरा वाक्य क्या बोले, यहां आए उन सभी को जीवन उन्नत करने की प्रेरणा मिले, ऐसी हम प्रार्थना करते हैं। नो कंपटीशन। Whoever falls in competition in professional careers, बच्चे होते हैं तो क्लास में एग्जाम में कंपटीशन में पढ़ते हैं बिकॉज दे आर क्वाइट इग्नोरेंट, दे हैव नॉट रियलाइज्ड लाइफ, दे हैव नॉट रेज्ड देयर कॉन्शियसनेस, दे आर नॉट एडल्ट्स, दे आर नॉट मैच्योर। आफ्टर प्रोफेशनल लाइफ एट द एज ऑफ 40, 45, 50, 55, if you constantly think of competition in your profession, I think we have lost the way of life, the path of life. फिर वो कंपटीशन अंत तक चलेगी, मैं पहले मरूंगा वो मरेगा। टेक इट लाइटली। कंपटीशन नहीं, नॉट द रैट रेस। महापुरुषों ये जीवन में से अपने जीवन में से सिखाते कि स्पर्धा में मत पड़ना। सभी लोग अच्छे हैं, अपना अपना कार्य करते हैं। बेसिकली ये थॉट रखना, ही इज एंजॉयिंग हिज डेस्टिनी, his hard work and his grace of God on him. I am enjoying the fruits of my hard work, my destiny and grace of God in me. He is he, I am I. मुंबई में से कौन आए, हाथ ऊंचा करें। 5-6 लोग आए। टाउन में कौन रहते हैं, वर्ली या नेपेन सी रोड की तरफ, तो पीछे 2-3 बैठे। अब नेपेन सी रोड या वर्ली के नीचे आप रहते हो, आपके 2 BHK 3 BHK में रोज अंतिलिया दिखता है। मुकेश अंबानी's residence, the costliest residence in the world. Today it is rated at $2.1 billion, that building. એટલે 16-17 કરોડનું એ residence. It is costlier than the Clarence House where King Charles stays in London. હવે તમે 3 BHK મારીને રોજ ગેલેરીમાંથી અંતિલિયા જો ક્યારે મેળ પડશે तो you will not enjoy your 3 BHK. अंतिलिया देखते देखते प्रेरणा यह लेनी है कि जीवन में पुरुषार्थ करना है, पहली प्रेरणा। दूसरी बात, जितना हो सके करना है, यह प्रेरणा ही लेनी है। वो नहीं लेनी है कंपटीशन वाली प्रेरणा, वहां कैसे पहुंचूंगा, तो तेरी चटनी हो जाएगी तो बीमारी बचेगा। So don't fall in the competition, you will fall in stress and stress can kill you. और अगर आप पढ़े हो और स्ट्रेस हैं, तो भगवान श्री कृष्ण ने अर्जुन को बताया। स्ट्रेस मैनेजमेंट के लिए भी एक डिफरेंट थिंकिंग मैं आपको देता हूं। स्ट्रेस मैनेजमेंट मैनेजर्स होते हैं ना, मेडिकल नॉन मेडिकल दोनों की बात कर रहा हूं। स्ट्रेस मैनेजर्स फ्रॉम द मेडिकल एंगल, फ्रॉम द नॉन मेडिकल एंगल, कहते हैं आपको पेंट योर ऑफिस ग्रीन, गो ऑन अ बीच फॉर अ लॉन्ग वॉक। तो जब कुरुक्षेत्र के मैदान पे अर्जुन स्ट्रेस में आ गए थे कि आई डोंट वांट टू किल माय एल्डर्स, आई डोंट वांट टू किल माय रिलेटिव्स, डिड कृष्णा टेक द चैरियट ऑन अ बीच? डिड ही पेंट द चैरियट ग्रीन? All these stress managers, what they tell you is just watering the branches. They are not watering the roots. You have to water the roots to keep the tree green. And watering the roots is your thought process, raising your consciousness again, and making your mind strong. Krishna made Arjun's mind strong, did not give him material facilities. क्या स्ट्रेस में ना, चलो कॉफी पी लेते हैं, what nonsense. आप स्ट्रेस में हो, चलो मूवी देखने चलते हैं, बच जाएगा स्ट्रेस, क्योंकि मूवी में अगर एक डायलॉग भी ऐसा आ गया, एक सीन भी आ सकता है क्योंकि मूवी में क्या है, 3 घंटे में सक्सेस, फेलियर, स्ट्रेस, डिप्रेशन, हाई स्पिरिट, अवार्ड, सब कुछ दिखाना पड़ता है. And those 3 hours, what they make it happen, doesn't happen in 30 years in real life. What did Krishna tell Arjun? Tarati shokam atmavit. He tells, believe Arjun that you are the soul and not this body. You are attached bodily with your relatives, with your friends, with your gurus. You are the soul. तेरे और मेरे कितने भी जन्म हो गए, ये पहला भी नहीं है और अंतिम भी नहीं है. So forget the bodily attachments. Believe yourself to be soul. Raise your consciousness. Second thing he told, man mana bhava. Keep your mind engrossed in me. Do what I tell you now. Because Krishna was the higher consciousness. So he directly guided Arjun. Do what I say now. Keep aside your thoughts. And the third thing he said, karmanyavadhikaraste ma phaleshu kadachana. He tells Arjun, Arjun, your job is to perform your duty. You are a warrior, you are on the battlefield. Perform your duty. Results I will decide. Results I will decide. साइंस क्या मत, इससे अर्जुन डिस्ट्रेस हो गए, स्ट्रेस चला गया, एंड ही फॉट, परफॉर्म दिस ड्यूटी, धर्म युद्ध. स्ट्रेस यहां आता है कि बॉडीली अटैचमेंट एंड ईगो. इफ यू डोंट अंडरस्टैंड साइंस इन द राइट वे, साइंस हैज द पावर टू इन्फ्लेट योर ईगो. You have to understand science from the spiritual aspect, because spirituality पहले पृथ्वी पे आई थी, बाद में साइंस आया था. When I was talking to 400 scientists at Tajland and Bandra in Mumbai, my topic was logic versus faith. I said, आप बोलते हो कि सब कुछ साइंस है, तो 5 मुख्य एलिमेंट तो साइंस ने नहीं बनाया ना, पृथ्वी, जल, तेज, वायु और आकाश. ये 5 जो बेसिक एलिमेंट हैं वो साइंस ने नहीं बनाए हैं. साइंस क्या करता है, ये 5 एलिमेंट का डिफरेंट परम्यूटेशंस एंड कॉम्बिनेशंस में मिक्स करके आइटम्स बनाता है. सो साइंस इज एक्चुअली डूइंग द जॉब वर्क ऑफ स्पिरिचुअलिटी. साइंस इज डूइंग द जॉब वर्क ऑफ स्पिरिचुअलिटी. ऑल ग्रेटनेस टू साइंस. अभी ऑर्गन डोनेशन की बात हुई, एक्सीलेंटली, एक्सीलेंट, अनबिलीवेबल अचीवमेंट ऑफ साइंस, होना ही चाहिए. सो ऑल रिगार्ड्स टू साइंस. But if science inflates your ego and tells you that it is above spirituality, that is the nonsense part of science. I can prove it logically. I will ask you all 2 questions. In both the questions, your answer will be a yes. Nobody of you will be able to tell a no. I challenge and guarantee. Shall I start? Question number 1. आपने कोई पेशेंट के लिए ये कहा कि मेडिसिन मैंने दी है, पेशेंट को दी है, लेकिन आई डोंट थिंक ही विल सर्वाइव मोर. और 20 साल के बाद भी आपके सामने वो खड़ा है. ऐसे प्रसंग डॉक्टर्स को बने, वेर योर जजमेंट हैज गॉन रॉन्ग, एक्सेप्ट इट नाउ. ओके. क्वेश्चन नंबर 2. किसी पेशेंट के लिए आप ये जज करते हो कि ही विल लिव लॉन्ग, तकलीफ नहीं है कुछ. In 5 days you get the news. अरे ऑपरेशन टेबल ऊपर ऑपरेशन करता करता पेशेंट बची जाए, डॉक्टर ऑपरेटर मर जाइए. What does that mean? I'm not telling that your judgment was wrong, because that's always a human error. I'm not telling the judgment was wrong. What I want to convey is what Krishna said. Arjun, you perform your duty. In place of Arjun, you put the word doctor. Doctor, not just doctor. Let's change the word. Family physician, you perform your duty. Results he decides. Yes or no? So when you understand this, you will be stressless. Dr. Neville Hacker, a physician, a cardiologist from Sydney in Australia, he had come to speak at an event at a medical conference in 1992 in Ahmedabad. At that time, we had the inauguration of the Swaminarayan Akshardham in Gandhinagar. We came to know that there is a physicians conference going on in Ahmedabad. So we went there and just begged 2-5 minutes to invite them to Akshardham. The organizers did oblige us, and so we asked that we'll be arranging the bus and everything if you people can come to Akshardham. So they happily arranged the tour, and we had about 30 physicians coming to Akshardham. We had a good guided tour for them. Dr. Neville Hacker, when he met Pramukh Sai Maharaj asked him a very simple question in traditional Gujarati, कि साहिब आप भगवान ने प्रार्थना करो छो, चर्च में जाओ छो? He was a Christian, so Pramukh Swami asked him, do you go to church? Do you pray to God? Dr. Neville Hacker said, Swamiji, my patient is my God and my hospital is my church. Fine, okay. Everybody lives with their ideologies, no issues. Second question Pramukh Swami Maharaj asked. Pramukh Swami Maharaj said, sir, has it ever happened that sometimes you say that the patient is fine and good and he passes away, and sometimes you feel that the patient will not live long and is right in front of you after 20 years? He said, yes, Swami, this is the question in my mind since 10 years. Why sometimes I go wrong? Why sometimes I totally fail in my judgment? Then Pramukh Swami Maharaj told him of this conversation of Krishna and Arjuna in Srimad Bhagavad Gita. Pramukh Swami Maharaj told Neville Hacker that we are the instrument, he is the doer. We must do to the best of our abilities. It's a human endeavor. It's a human dignity that to the best of your knowledge and the best of your practices and best of your experience, you must serve the patient. But believe that after my putting best knowledge, best experience and best treatment, still the final result he decides. And that is why we all write RX at the top left of your prescription. That Latin word says, God thou take care. लिखते हैं लेकिन मानते नहीं है, इसलिए स्ट्रेस आता है. लिखते हैं लेकिन मानते नहीं है. जो लिखते हैं मानते नहीं है, तो ये मतलब क्या हुआ कि वो छोटा बच्चा क्रेयॉन लेके वॉल पे कुछ भी लिख देता है, वो आपने यहां कुछ भी लिख दिया. इट इज इक्विवेलेंट टू दैट एक्ट. Believing him to the all-doer, then you can accept the happenings of your life. And the biggest achievement, success in life is accepting wholly, positively the happenings in life. Stress kahan se aata hai? Why did this happen? Isn't it? Yes or no? Raise your hands if you say yes. Why did this happen? Yahan se stress aata hai na? So did God sign an MOU with you when he sent you upon this earth? कि जा बेटा पृथ्वी पे, whatever you do will happen goody goody. Any of us do? We have an MOU. Life is like a sine wave. Ups and downs are part of life. This is raising your consciousness to believe the all-doership of God and thus accepting all happenings in life and remaining stable, happy, satisfied and at peace. This is called success in life. This is called success in life. I'm into the final 5 minutes of my talk. Another good aspect of thinking different is, it is a bit more critical, but very energizing. We all are doing it, but we need to do it more consciously. And it can help us in many ways. Living a life as prescribed in the scriptures. Trying to cultivate the thoughts, feelings and emotions as prescribed in the scriptures like Srimad Bhagavad Gita, Mahabharata और रामायण. आपको चैलेंज और दावे के साथ मैं एक बात कर सकता हूं कि आपके जीवन में से कोई भी एक प्रसंग आप उठा लो. Tonight before you go to bed, just pick up any happening of your life, पॉजिटिव और नेगेटिव. वो रामायण या महाभारत में जरूर बना होगा वो प्रसंग. दैट इज द डेप्थ ऑफ दिस एपिक्स. एनी हैपनिंग इन दिस पॉपुलेशन ऑफ 8 billion अपॉन दिस अर्थ, एनीबडी कैन पिक अप देयर एनी हैपनिंग ऑफ लाइफ दैट हैज हैपेंड इन रामायण और महाभारत. इफ यू हैव read the scriptures well, you easily could relate. मेरे घर में जो झगड़े हुए हैं उसमें मेरा रोल क्या? Knowing your role is half solved. The problem gets half solved. घर में झगड़े हुए तो आपको पता तो चलना है कि मेरा रोल दशरथ का है, राम का है, कैकेयी का है या मथुरा का है. And knowing your role in the problem is half solved. That is, problem is half solved. No need of social counseling. जो सोशल काउंसलिंग में जाते हैं उनको मैं बोलता हूं कि आप रामायण पढ़ लो, महाभारत पढ़ लो, श्रीमद भगवद गीता पढ़ लो, भगवान स्वामीनारायण का वचनामृत पढ़ लो. सोशल काउंसलिंग की जरूरत ही नहीं है. आपके जीवन में जो घटना बनी है वो वहां बनी है. तो उन पात्रों ने क्या सोचा उस वक्त, क्या किया, कोऑपरेट. and you'll be out of your issue. कॉपी पेस्ट ही करना है, एज सिंपल एज दैट. और वही बात डिफरेंट लैंग्वेज में डिफरेंट शब्दों में सोशल काउंसलर कहता है. सोशल काउंसलिंग में जाता है कि यार मेरा डिवोर्स हुआ, मैं क्या हुआ, आई एम लाइक अनहैप्पी एज सिंगल. वो काउंसलिंग करने वाला ही 1 साल पर डिवोर्स लेके बैठा है. वो क्या काउंसलिंग करेगा आपको? जाता है सोशल काउंसलिंग, क्या ड्रिंकिंग हैबिट बहुत बढ़ गई है, बीवी चिल्ला रही है, बच्चे नाराज हैं, क्या करूं? तो वो एडवाइस देगा कि डू दिस, टेक अ ब्रेक. इफ यू आर डूइंग इट 6 times in a week, स्टार्ट हैविंग ब्रेक्स, डू इट ऑन मंडेज, वेडनेसडेज एंड फ्राइडे. थ्योरी लिख के देता है. वो बाहर जाता है पेमेंट करने के बाद, इमीडिएटली ड्रॉर में से वो खुद बोतल निकालता है. एम आई टॉकिंग समथिंग सेंसिबल? होता है ये. Pick it from the scriptures, pick it from the characters of the lofty epics, and you will enjoy life better. You will be able to solve the problems of life in a much, much better way. And the last thing I would like to tell is, जो आप सभी में है, सेवा करते हो. कोई एक प्रोफेशन ऐसा है पृथ्वी पे जो सबसे ज्यादा सेवा करता है, वो डॉक्टर्स का प्रोफेशन है. बाकी सब प्रोफेशंस ऐसे हैं कि वो लोग ये नहीं सोच सकते कि चलो मैं संडे कैंप करके एक चार्टर्ड अकाउंटेंट तो लोगों को टैक्स की टिप्स फ्री में संडे को दूं. वो वहां पे कैंपिंग नहीं आता है. कैंप कहां आता है? सिर्फ एक ही प्रोफेशन में, मेडिकल प्रोफेशन. द मेडिकल्स डू इट, सो इट इज कॉल्ड द नोबल प्रोफेशन, एंड सो दे डॉक्टर्स आर कॉल्ड डेमीगॉड्स. और कोरोना के दौरान डॉक्टर्स ने जो कार्रवाई की है, अनबिलीवेबल. द होल वर्ल्ड इज ऑब्लाइज्ड टू देम. So let me take this opportunity today in front of all you doctors representing common man in the society that we are highly obliged to you all for taking care of us during corona times. तो सेवा हम बहुत करते हैं, अच्छी तरह से करते हैं, लेकिन सेवा किस तरह से करनी है वो मुद्दा बोल के मैं पूरा करता हूं. वी ऑल डू सेवा, सर्विस हम करते हैं, निस्वार्थ भाव से करते हैं, लेकिन थोड़े अंतर के भाव ताकि हम उनको ये सेवा का ज्यादा लाभ मिले. In 1992, when we had the inauguration of Swami Nakshadam in Gandhinagar, we had a huge festival for 1 month. We had 17,000 volunteers. L.K. Advani जी पधारे थे हमारे मेहमान के रूप में, हमारा निमंत्रण को मान देते हुए, और पूरे महोत्सव स्थल पे घूमे. वहां किचन देखा जहां से रोज खाना पकाते थे हम 1.5 लाख लोगों के लिए. और वो उत्सव में वी यूज्ड टू सेंड टी और करी बाय पाइपलाइंस. 2 किलोमीटर की पाइपलाइन चलती थी. 2 किलोमीटर दूर आप सुबह में टेप खोले तो चाय निकलती थी, वही टेप दोपहर को खोले तो दाल निकलती थी, वही टेप आप खोले शाम को तो करी निकलती थी. तो ये एक वाक्य से आप समझ पाएंगे कि इवेंट किस स्केल का होगा, मैनेजमेंट किस स्केल का होगा. अडवाणी जी वो एकदम अंतर से बोल उठे कि अद्भुत है, और दम रह गए. उन्होंने हमारे स्वयंसेवक को कहा कि आपने बहुत अच्छी व्यवस्था की. नहीं, हमने नहीं की है, हमारे व्यवस्थापक जो आइडिया देने वाले हैं, काम करने वाले हैं, प्रेरणा देने वाले हमारे संत है, वो करते हैं. हमारे संत को मिले जो किचन डिपार्टमेंट के मुख्य थे. अडवाणी जी ने कहा कि स्वामी जी आपने तो अद्भुत आयोजन किया है. हमारे संतों ने कहा नहीं, प्रमुख स्वामी महाराज के आशीर्वाद से होता है, हमने कुछ नहीं किया. जब प्रमुख स्वामी महाराज को मिले तब अडवाणी जी ने कहा स्वामी जी अद्भुत आयोजन, कितना बड़ा महोत्सव आपने किया. प्रमुख स्वामी से अडवाणी जी नहीं, भगवान स्वामी की कृपा से हुआ है. Advani he intelligent guy. When he was on the dais after his felicitation, in the speech he mentioned this. और वे बोले कि यहां जो सेवा करते हैं वो कोई क्रेडिट की अपेक्षा बिना करते हैं, क्रेडिट लेना नहीं चाहते हैं. ये महोत्सव की सफलता का राज मुझे यहां ये मौके पे मिला. तो सर्व करते हो when you are in the camps on weekends or whether you are in the hospitals. Believe that I am not treating the patient, I am just an instrument. He is treating the patient and I just have to treat and wish him well and pray for him. तो सेवा में क्रेडिट लेने का प्रयत्न मत करना, तो वो सेवा का फल भी कम हो जाता है, पुण्य भी कम हो जाता है. सेवा की तो निस्वार्थी. पेशेंट का आभार व्यक्त करना कि आप लोग यहां पधारे तो मुझे ये सेवा का मौका मिला, आप लोग यहां पधारे तो मैंने आपकी सेवा की, वो एटीट्यूड नहीं, आप पधारे तो मुझे सेवा का मौका मिला. दैट हम्बलनेस इज ग्रेटनेस. दैट हम्बलनेस गिव्स सेटिस्फैक्शन एंड पीस. जो हम बात करें, दैट इज रियल सक्सेस इन लाइफ एंड दैट इज द अल्टीमेट सक्सेस इन लाइफ. आखिरी एक प्रसंग कह के मैं पूरा करता हूं कि सेवा करते वक्त किस प्रकार के विचार रखते हैं. During Corona times, one of our BAPS volunteers, born and raised in BAPS from our children forums to teenage forums, Dr. Dilip Patel in Pennsylvania. He was watching TV and he saw the clarion call of the governor of Pennsylvania that we want a medical practitioner for St. Quentin prison, which is the highest security prison of United States, housing वायलेंट प्रिजनर्स, जिन्होंने 2-5 खून किए हैं, इस प्रकार के सब प्रिजनर्स वहां पे हैं. एंड नोबडी वाज रेडी एज अ मेडिकल प्रैक्टिशनर, क्योंकि वहां तो अगर इंजेक्शन में उसको थोड़ा भी अगर दर्द हुआ तो भी वो गला दबा देगा, इतने वायलेंट होते हैं. डॉक्टर दिलीप पटेल अंतरात्मा में से, जो बचपन में से बीएपीएस में से संस्कार मिले थे, और प्रमुख स्वामी महाराज जो शब्द बोले थे, इन द गुड ऑफ अदर्स लाइज आवर ओन. प्रमुख स्वामी महाराज का एक जीवन सूत्र था, अन्य के सुख में हमारा सुख. It's a call from within. He called the governor's office. I'm going. These are my credentials. He drove 450 miles to St. Quentin prison. He showed his credentials, so he was approved to vaccinate. He booked a room in the nearby motel at his own cost. Normally, he used to treat 30 to 40 patients. Here at St. Quentin prison, he started treating more than 150 patients a day. एक पेशेंट उनके सामने आया जो प्रिजनर था, सभी प्रिजनर्स थे. दोनों की आंख एक दूसरे में मिली, दोनों चौंक गए, बिकॉज दे रिकॉग्नाइज ईच अदर. डॉक्टर दिलीप पटेल एंड दैट प्रिजनर, दे रिकॉग्नाइज ईच अदर. दिलीप पटेल ने क्या रिकॉग्नाइज किया कि माई बेस्ट फैमिली फ्रेंड, हिज वाइफ एंड हिज 2 लिटल चिल्ड्रन वेर मर्डर्ड बाय दिस पर्सन. बेस्ट फैमिली फ्रेंड ऑफ 30 years, his wife and his 2 little under teenage children were murdered by this prisoner. In America, the medicos have the right to refuse. Right to refuse him. अगर डॉक्टर बोले कि I don't want to treat this patient, it is also my human right to say no. So that is an official right given to the medicos in US. एक बार क्षण के लिए विचार आ गया, एक बार क्षण के लिए कि I have the right to refuse. I don't want to vaccinate this person. He has killed my family friend, 4 people, and that too 2 children. Very next moment उनको विचार आया, I have come to serve. Today I don't have to see him as a doer of a crime. Today he is a patient in front of me. He deserves treatment. And my Guru Pramukh Swami Maharaj has taught me, in the good of others lies our own. The word others does not discriminate. Others means everybody apart from me. He vaccinated that person, and that person had tears in his eyes. And he said, for the first time, I have cried in my life. See, this is raising your consciousness, strengthening and making your mind healthy, going beyond the ordinary human behaviors. And that is real success of life. So thank you very much for patiently listening to me, and all my prayers for all of you, that may you treat all patients. You are treating them well, but treat them more well for their benefit, and may my Guru Mohan Sai Maharaj bless you all. Thank you very much.
Jai Swaminarayan. Now may I request to come on the stage Dr. Pragnesh Shah sir, Dr. Pragnesh Vachrajani sir. Dr. Nitin Shah sir, Dr. Akshay Patel sir, FPA Vadodara, to facilitate Swamiji. આગળ લઈ જા આગળ લઈ જા Sir, please. Now may I request to come on the stage Dr. Darshan Banker sir, CEO Banker Group Hospital, Dr. Mitesh Shah sir, IMA President Vadodara, Dr. Dhiren Mehta sir, past National Treasurer FFPI, Dr. Abhay Dixit sir, past President FFPI, Dilip Deshmukh Dada sir for lamp lighting.
शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योति नमोऽस्तु ते दिव्या दिव्या रे दीपत्कार काने कुंडल मोतीहार दिव्याला पाहून नमस्कार तिळाचे तेल कापसाची वात दिवा तेवे देवा पाशी उजेड पडे विष्णू पाशी माझा नमस्कार सर्व देव देवतांपाशी ये ग लक्ष्मी बैस ग बाजे माझं घर तुला साजे घरातली इडापिडा बाहेर जाऊ दे बाहेरची लक्ष्मी घरात येऊ दे घरच्या सर्वांना उदंड आयुष्य सुख समाधान शांती.
I request Dr. Samir sir. Dr. Samir Shah sir. Dr. Amit Misra sir and Sriji Thakkar, please come on stage. Sir, please come. Manan.
चालू तुझं काम चालू राहतं. चालू कर दे भाई.
Now I request to Swamiji, please facilitate Dr. Darshan Banker sir for Clinical Excellence Award. Felicitate. Dr. Pragnesh Shah sir, National President FFPI. Sorry.
Lamp liners.
Dr. Mehul Salat sir, Treasurer FFPI. Dr. Mehul Salat sir. Dr. Pragnesh Vachrajani sir, Honorable Secretary, FFPI. Dr. Pragnesh Shah, sir, Honorable National President, FFPI. Dr. Samir Shah, sir. दिलीप देशमुख दादाजी.
फ्लावर આપી દો મિતેશને ફ્લાવર.
डॉक्टर मितेश शाह, सर. डॉक्टर मितेश शाह, सर. श्रीजी ठक्कर, सर. दर्शित ब्रह्मभट्ट जी. जय स्वामीनारायण.
मनन
सेशन चालू कर दो.
Now I request Dr. Darshan Bankar, sir, to be on stage for his frequently asked questions for the renal degeneration, hope or pray for the hypertension. Dr. Darshan Bankar, sir, please. Dr. Darshan Bankar, sir, is a renowned cardiologist mentor to me. He had performed more than 80,000 angiography and 40,000 cardiac procedure. Dr. Dhansal Bankar sir, please.
Good afternoon. I know after having so much of insulin and so much of motivation, it's difficult to concentrate for a scientific topic now. And as the time goes by, and with so much motivation which has come to your life in last 15-20 minutes, many of you must be thinking that they should stop practicing also. So, let me define my happiness. I am happy when I treat patient and patient gets cured. That is number one happiness for not only me, most of you. And the biggest sadness in our life is when we fail to cure a patient. Okay, so that is our definition of happiness and success is when you treat patient and patient gets cured. That's how we look at it. The topic is very interesting. Many of you know about it. I'll just go and brief you about it. It is Eureka. You know what is Eureka. I think most of you will know what is Eureka. Eureka is the exclamation for something which you have invented or found out, which was already existent. The idea was Eureka is basically the word which was used by a Greek mathematician, Archimedes, and he was in the bathtub, and then he found out when he went inside the bathtub, the water spilled out. And so he found out a method to measure the volume of the water. So he, in joy, he ran on the street naked directly from the bathtub telling Eureka, Eureka. That's the story. So for medical field, this therapy is like Eureka. It's the hope of ray, what we call. And starting with, we have huge number of patients we all know is having hypertension. Many of them are treated and controlled. Many are treated but uncontrolled. And almost 1/3 are untreated. And apart from, like diabetes, hypertension also is one of the leading cause for all the morbidities and mortalities happening in lifestyle diseases. So this is how we look at it. I would request people not to please, just keep your silence please over here. There has been a lot of things which is happening in blood pressure, you all know. I'm not going into detail of this because I don't want you people to get bored with science and data and the analysis part of it. I just want to show you something which is happening now in the world, in India and in city of Baroda. So we have a lot of challenges in treatment of blood pressure. The thing which is very important and many of you must have faced, how many of you see resistant patients with hypertension? Most of you will see, like patient is already on 3 or 4 drugs, still his blood pressure is 180, 110, 200, 120, he is on all the drugs, still nobody can control. That is what we call hypertension. I am not going into detailed definition of this. But in general, patient with 3 or more drugs, the uncontrolled pressure is a resistant hypertension. And for such patients, we have a therapy now which is available. And you will be surprised to know almost 10 to 15% of the population, hypertensive population, has resistant hypertension. So which is quite a big number, especially in India. There are various therapies now available for hypertension. like barrier reflex amplification therapy, AV fistula creations, carotid body ablations, but the most important and most performed therapy now is renal denervation therapy. So what does it do? I'll just give you the brief what renal denervation do. So basically renal denervation is ablation of the renal sympathetic afferent nerves. So the central sympathetic drive origins from the kidney. So what we do is the sympathetic nerves over here are ablated at the kidney level only. So the sympathetic drive does not go into the brain, and we understand the central neurogenic mechanism is abolished for causing hypertension. So obviously there are many advantages of this thing. So basically there are sympathetic nerves are adjoining, or it is just outside the renal arteries on both sides. So we can do a percutaneous catheter based technology where we can ablate these sympathetic nerves on both sides of the renal arteries. That is what the principle of renal denervation therapy is. It has been used for various things now, for hypertension, for sleep apnea, for post-MI patients, cardiorenal syndrome, and insulin resistance. These are the umbrella where we can use, wherever there is sympathetic overstimulation, you can use this therapy. Obviously, I have already told you the anatomical location of this thing, and this is how the catheter looks like of the renal denervation therapy. The procedure itself is not very difficult. It is like very safe procedure and can be performed maybe in 1 hour's time. And now the technology has also advanced to a very great extent for this therapy. Basically, it's a Medtronic Simplicity catheter system which we are using nowadays. And it has a multiple discrete treatment points over here. And the therapy with newer generation of catheter. And the catheters has a AI technology inbuilt. So it can sense the temperature, it can sense the amount of energy given. And the catheter itself decides how much energy has to be given. So that kind of catheters are now available and which we are using already. And with that therapy, it has become more effective and the procedure has become more successful. This is one of the cases which we did recently. Mr. Bepiwala, with 52-year male with 220 pressure and was on multiple drugs, and all secondary hypertension causes were excluded. And we put a catheter inside the renal artery, and then what we do is we put a renal denervation catheter and impart the energy into the renal arteries so that all sympathetic stimulations or all sympathetic nerves lying adjacent to the renal arteries are ablated. So it is done on both sides, left and right renal arteries. And this was post-procedure day 2. The pressures were 140 by 90 almost. Patient was already on only 2 drugs. And at 6 months follow-up, we had patient controlled on 140/90 pressure for almost 6 months. So that is wow. This is very interesting case. That is why I put this case. This is a 70-year-old female. She was obese, diabetic, weight of around 115 kg, and had an obstructive sleep apnea also. And she was from Valsad, and we did 180/100 pressure on 4 drugs, and obviously she was on multiple oral hypoglycemic agents also. And we did this thing, and this was like I was one of the first in India to do this renal denervation therapy. There is a story behind it that I was, my wife was watching TV, BBC, at one point of time, and she saw an interview of a cardiologist called Horst Sievert from Germany, and he was talking about this technology on BBC. So she told me that such thing is happening. So I contacted him through email, and he replied that we are going to have the first learning session for all over the world for renal denervation therapy. Why don't you join? So I was the first one in first 50 cardiologists to be trained for this therapy in 2011. So that's how I started doing renal denervation therapy. Now the issue at that point of time in India, the catheter were not available in India. So obviously, as the Indian, we know how to jugaad things. So I thought about it, and we use, ablation catheter in EP studies, RF ablation, which was like everybody does it for years to now. So what I did initially for few cases, that I use a RF ablation catheter of the heart into the renal arteries. And we did almost 25 renal artery ablations using RF ablation catheter of the heart, used for EP studies. And we were successful, and we did it quite regularly at that point of time. Then we got this newer catheter available in India, and now we are routinely using that catheter for all our renal denervation therapy. By now we have done almost 40-45 renal denervation therapies. Almost 30 patients are still in follow-up. The rebound hypertension happened in almost 6 patients at the end of 3 years, almost average of 3 years, that their blood pressure came back to we went to square one. But almost 20 to 25, that is almost 60% of the patient, the resistant hypertension had gone out of the work. So there are various studies done for this thing, simplicity trial. Initial results were not very fantastic, but the newer trials have shown a very promising result. And my personal experience of 50 patients we are one of the largest series in India, and our experience has been very gratifying. If you select your patient properly in such cases, you get a fantastic result, and it gives a long-term result also in such cases. And the newer generation of catheter, the success rate has gone up like 98 to 99%. So in conclusion, it's a novel and safe approach. It is absolutely safe form of therapy, and selective denervation of renal sympathetic nerve is a potential to reduce significantly the blood pressures. And obviously it is one of the major therapy available for resistant hypertension. And various trials and current guidelines have recommended renal denervation therapy should be used for resistant hypertension. It has already come in the guidelines now. And this was my attendance certificate. And I thank you all for patient hearing. Thank you very much. Any questions? No. It is a radiofrequency ablation which does not cause any intimal injury also. Well, there are two ways of managing it. One is to do a re-procedure. Most of them were not ready. So we have to manage on drug. The way we are managing all the resistant hypertension as of now. This would be around 4.5 lakhs as of now. It will come down when the catheter becomes more, obviously it's the technology which is patented as of now. So for first 5 years it is always costlier to do such therapies. Yeah, I think so. It is covered by insurance. Okay, thank you very much.
Thank you so much, sir, for your exceptional presentation. Sir, please stay on stage. I would like Dr. Ashish Patel, sir, to honor Dr. Darshan Bankar, sir. For the next session, I would like to invite Dr. Jay Shah from Vadodara, Dr. Abhay Dikshit sir from Ahmedabad, Dr. Vibhakar sir from Mumbai, and Dr. Rajan Desai from Bhavnagar to chair the session. Now I would like to invite Dr. Amit Mishra sir on stage and enlighten us on status of cardiac surgery in India. I would request the chairperson to introduce the esteemed speaker.
हाँ, ये रहा पॉइंटर और ये स्लाइडर. My sincere thanks to the organizers for giving me the opportunity to discuss my subject and its problems here. And first of all, I'd like to say that
Excuse me,
the
sir.
people who are from Gujarat.
Excuse me, let me introduce you first,
Sorry.
please.
Very sorry.
Dr. Amit Mishra, sir. He is a professor of pediatric cardiac surgery at the UN Mehta Institute of Cardiology and Research Center for the past 18 years. The first formally trained and qualified pediatric cardiac surgeon in Asia and Europe. Great, sir. Great. Performed nearly 11,000 pediatric heart surgeries in the past 18 years. He has performed 7 innovative pediatric cardiac operations, and he has developed a custom-made device for causing ventricular septal defects, that means VSD, which got the patent. Contributed the chapters to the textbook, and he has, to his credit, over 80 articles in the national and international journals. Thank you, sir. Developed a custom-made device for causing VSD, and award golfer in his leisure time. Dr. Mishra is also a deeply spiritual person. Board of Advisory for Pediatric Cardiac Surgery to SGPG Lucknow and tens of Ramadan, Egypt. Thank you. Thank you, sir. Now I request you to present your presentation.
Thank you, sir. Thank you very much. So, I was at the point, sorry I started without the permission of the chair. I'll say the people who are born in the Gujarat and staying in Gujarat and their kids are from here, they are very lucky because the entire operation, pediatric cardiac surgical operations, are free of cost in this state only. It is not free anywhere in the world. Even the insurance is not covering it because of some reasons. We are trying, if the insurance covers it, then it's a very good thing. But still with the Prime Minister's yojanas, the newborn or a pediatric cardiac surgeons can get the operation done in the private hospital, which has started recently. This is the state of our country. We are not still comparable in pediatric cardiac surgery as a workload or as a patient load with Western population also. We are far behind, and it really needs a lot of people to join this specialty. The reason is it's not a very well paid specialty, and it is always there is some of the emergency. You can't leave the city, you can't go for 3, 4, 5 days out, otherwise you have to plan accordingly, or somebody has to give the cover to you. When I came to Gujarat, for all practical purposes, I was the first qualified pediatric cardiac surgeon in the Gujarat, and the institute was also just started taking over. Before that, the patients used to go in Chennai or Bombay or Cochin. These are some Indian statistics, but in short, I'll say the incidence of pediatric cardiac surgery is 1 per 100. So 1% of the babies born are having the incidence of congenital heart surgeries. It is the data of the western part of the country only, where I'll not go in detail which is the disease which is common here and there. And but in place, I will just go for a simple thing, that as a physician, I'll just say that these are the diseases which are curable. Once you identify and operate them properly, they are curable. The babies are absolutely normal for the entire life. The other things are a bit complex, so one need to be experienced enough to deliver the result in these complex operations, number one. Number two, infrastructure should be there, and finances again, but for the Gujarat, in everywhere in the country, the finances are a big issue. So any simple VSC closer will cost 4 lakhs or 5 lakhs rupees in a hospital at Mumbai or anywhere else. So this is the big, and the young couples having a newborn baby, they are not financially well prepared also. But now there is an era of fetal echocardiography. So fetal echo is done, and now regularly I am getting at least 8 to 10 patients, or 8 to 10 mothers who are attending my OPD to find out what is the overall prognosis of these defects. So fetal cardiac surgery, fetal echocardiography is changing the scenario of the subject. And I'm sure the near future is going to be good only for all of us. But once you don't know what the baby is developing inside, so whether something can be done now or you have to look for the other alternative options. See, this is not the surgery only. It's not that every patient who has got a heart problem has to go for the surgery. That's not there. So, okay. So these are few devices which are developed and a cardiologist can plug in the defect of the heart, whether ASD, VSD, PDA, the simple congenital conditions, if they are suitable for the device, one can devise it and there will be no scar and all that, and they are going to be all right forever. But there is some complication if you try to attempt the device, that also needs, because it's a closed heart, nothing is in front of your eyes. Sometime the device or coil split somewhere, then we have to rescue the situation. Now some common heart surgery which I'm sure all of you would like to know. This is a second ASD. It's a large defect causing left to right and symptoms of the left to right shunt, that is failure to thrive and all. This is one of the simplest defect. Just we close this with a patch, open heart surgery. You have to go and bypass, clamp, arrest the heart and then close this defect. The secondly is a ventricular septal defect, VSD. There are so many types of VSD, and I have developed my own techniques to close this VSD during surgery by using my own custom-made device. So these are the VSD which can occur at any point. It can occur apex, mid-muscular, perimembranous area, depends which area and the size of the VSD, whether it can be closed or not. So actually it's a handmade device. Almost say 15 years back, I thought why not we should try the VSDs which are at the apex, which is far from the tricuspid valve. You can't see the margins, you can't take a bites around that and close it. So the only option was there to do a left ventriculotomy, see the VSD and close the VSD from the left side being the systemic ventricle, and any time it will form aneurysm or pseudoaneurysm, but the perfect closure, the only technique which was there was to open the ventricle and then operate. And this is how it's, you have seen the photographs, this is how it's simply it is there. It's the device is made, and from the left side the device is passed, and then you just pull the last figure, you just pull the device and plug. It's like a plug, electricity plug. Just plug it the device without doing anything, and the VSC closed for the ever. Till now I have done more than 100 such patients, and this device is used everywhere in the country, outside the country also. Recently I was in a conference at Washington DC, there I presented my device. And it has got patent, but there is no cost. I am not selling it to any company because the defects are less. In my practice, I get 10, 12 cases over a year with such a high volume center. So less likely that any isolated apical VSD anyone will get. In fact, I get references for these kind of VSD closure from all over the country. Then this is PDA. PDA is a patent ductus arteriosus, and one can just do it thoracoscopically, transaxillary, a small incision. It's a 2 centimeter incision, you can find out the PDA and can clip it. One of the simplest congenital heart surgeries. And this is again, when you do a thoracotomy, proper thoracotomy, and then you find out the PDA and you just simply you can ligate it. This is coarctation of the aorta. Coarctation should be diagnosed as early as possible, and then one should repair it. Just take out the quart portion and do end-to-end anastomosis. The problem with the coarctation is that once the child develops the hypertension, say you come to know across the 4 years or 5 years of age, after that the other things are okay, can be operated and other things will be taken care, but most likely he will continue to be hypertensive for the entire life. So once you get a patient with coarctation, please refer them as early as possible so the problem can be fixed. Otherwise, if you get adult patient, then in that situation, there are so many collaterals, entire chest wall, if you touch and it bleeds. So we have to find a way to bypass from ascending aorta to descending aorta, put a tube without touching the coax segment, and the rest of the life they will survive with this connection. Again, the flow and circulations will be okay, but blood pressure will be optimized to a level, but then you have to continue with the antihypertensive drug for the lifetime. This is tetralogy of Fallot, one of the very, very common congenital heart disease. I am sure all of you must have seen. Sometimes we get the tetralogy is such a balance that you don't have any symptom till 40 or 50 years of age. So when 40, 50, somebody accidentally diagnosed, and then they will refer to us and we have to do. So the technique is nothing. You have to open the right ventricular outflow tract, remove the muscles which are causing the obstruction, close the VSD, and this is the patch which is put on the right ventricle. So the right ventricle outflow tract is augmented and the VSD is closed, and that was the tetralogy is. Earlier you do, better the result. If you do in adult patient, then you put a patch or you resect the muscle, there always be muscles and everything will be healed by fibrosis. And once a fibrosis is there, they are the spots where arrhythmias can generate. And sometimes the cyanotic cardiomyopathy or the arrhythmias are usually the cause of the death. So one should try to do tetralogy as early as possible. Baby of 3 months, 4 months, we comfortably operate. And in the Western world, they are doing newborn tetralogy, because once the newborn you operate, there is no hypertrophy of the muscle at that time, and resection is good. So the pulmonary blood flow is good, and usually in newborn, the pulmonary valve is also good. So it is just like a simple VSD closer, and they will be all right forever. So the crux of my talk is that once you have any suspicion, whether in the fetal echocardiography or in the future, or saturations are not maintaining, then you refer them to the cardiologist or a pediatric cardiologist or surgeon to make a decision. Then sometimes the main pulmonary artery stump is missing. There is no main pulmonary artery. The ductus is the one which is supplying the blood to entire pulmonary circulation and then to the body. Some collaterals we develop, that is called as MEPCAS, that collateral will take care of the flow of the blood into the lungs and then to the entire body. They will be deeply sinused, but we can fix it. And here it is showing that we are using a conduit. This is a conduit, usually jugular vein of the cow, which is used, and then you connect that vein so that right ventricle to pulmonary artery connection is maintained and the child can have a normal life. But the only thing is that this conduit will not life long. So maybe after 10 years, 12, 15 years, one has to go for only conduit replacement, and that's all. This is TAPVC, total anomalous pulmonary venous connection, where the pulmonary veins are not joined to the heart and only the flow from the pulmonary veins is coming to the right side. ASD is there, and then with that they will survive. I've got a some politically well-connected person from this place only. So operated in emergency. Actually, in pediatric cardiac surgery, TAPVC is a dire emergency. The diagnosis is the indication. Once you know, irrespective whether 11 o'clock or 12 o'clock, arrange blood and all other things, and we have to take the patient in the middle of the night also. So this is the one which is a dire emergency. Second, spell. Spell still one can manage medically, but this problem will not be managed medically. And the best part of the disease is this: once you operate, they are cured forever. They are normal forever. So there are very few diseases which you get a result 100%. So please never ever forget to refer them as early as possible. This is
so you have in 2 minutes, sir.
Okay, fine. Sure. This is transposition where we have to do the switches, where the two arteries has to be shifted and the coronary artery also need to be transferred. It's a very common operation. Then Alcapa, where the coronary artery is coming from the pulmonary artery, we have to shift it back to the aorta, new aorta. And this is the recent thing in our specialty. That's 3D printing. Once you do MRI, with MRI you get a 3D print. Like you will get your heart into your hand. You can see what is the problem, and you can see what I am going to do. You can practice whether I will be able to fix it like this or not. So this is a 3D printing which is coming in the market now. This is arch repair, aortic arch repair, we have to augment, and this operative photograph of the arch repair. This is 3D printing, and still we get a patient where the problems are not diagnosed for so many years. So this is mother and the child, both I operate for tetralogy of Fallot. Then recently we are getting the patient from all over the world also, mostly from the African countries. This girl was from Middle East. Thank you very much. Thank you for this.
Thank you very much, sir.
Any questions?
Any questions?
Thank you.
Please, please.
Thank you, sir. It was a fantastic overview of critical area of research. I request the chairperson to honor Dr. Amit Mishra, sir.
Yeah.
Dr. Amit, sir, I would request you to pick a coupon for lucky draw.
Number 332, 332. Yes.
Thank you, chairpersons. You are requested to receive your token of honor from the point of honor corner for family physicians. Moving ahead for installation, I would like to invite Dr. Sameer Shah, sir, Dr. Pragnesh Shah, sir, Dr. Pragnesh Vacharajani, sir, Dr. Ashish Patel, sir, Dr. Dipti Shah, ma'am, Dr. Nitin Shah, sir, Dr. Abhay Dikshit, sir, Dr. Dhiren Mehta, sir, Dr. Ketan Shah, sir, Dr. Vikul Shah, sir, and Dr. Manandani, sir, on stage. Dr. Ashish Patel, sir. I would request Dr. Ashish Patel, sir, to please come on stage. He is President of Family Physicians Association, Vadodara. Sir, please give a welcome speech.
Okay. Dear friends, we can't say it is good morning. At the end of the day, we have enjoyed a lot. I hope everybody has enjoyed the medical feast, cultural feast, and everything, real feast. It is not time to welcome, but I hope everybody has enjoyed and give some suggestions if there is any loophole. Thank you.
Thank you, sir. Now I request Dr. Pragnesh Shah, sir, to give a welcome speech.
Yes, good afternoon, friends. Now I know that all are waiting for lunch. So without wasting much time, I hope you all enjoyed the conference. And thank you, all of you, to be there in the hall from 9 a.m. yesterday to till 1 p.m. today. Thank you. I wish you to see all of you at Surat also. in 2027. Thank you very much.
Thank you, sir. Now I would request Dr. Pragnesh Vacharajani, sir, for Secretary Annual Reports.
Good morning, everyone. The annual report is put on the official website of FPI, that is www.ffpindia.org. Thank you very much.
Now I request Dr. Samir Shah, sir, to come forward and say a few words.
Good afternoon, friends. And while sitting on the chair, I realized that what I need to speak. Very few words, but I'm very much happy that family physicians of the country have a get-together and exchange of the thoughts. The government is also on the way toward this kind of the practice, and we all know that Ayushman Bharat Yojana has come, telemedicine has come, and I think the family physicians are the backbone of the all fraternity. जब हम छोटे थे तब हमने कुछ गेम प्ले की हुई है कि एक रस्सी होती है, रस्सी पे एक हम कंकर बांधते हैं, फिर उसको घुमाते रहते हैं, फिर थोड़ी स्ट्रिंग हम थोड़ा सा उसको ढीला करते हैं, कंकर थोड़ा आगे जाता है, फिर उसको घुमाते हैं, थोड़ी सी हम ढील करते हैं, कंकर और आगे जाता है. आई थिंक फैमिली फिजिशियन हैव डन द सेम थिंग. रस्सी को थोड़ा ढीला किया है एंड सुपर स्पेशलिटी हैज डेवलप्ड. सो दैट इज द ऑरा. थैंक यू वेरी मच एंड विश यू ग्रेट सक्सेस.
Lastly,
Dr. Samir Shah, sir, is a professor of skin and dermatology at now SMS Medical College. He is the former medical director of the ESIS scheme, Government of Gujarat. I will, if I introduce him in detail or in brief also, it will take 7 to 8 minutes. So I will say he is a very good administrator and very good clinician also. Thank you very much.
I will request our President to give a moment to Dr. Samir Shah, please. Now we'll move on with the awards. Now, we have heard today morning Dr. Jayendra Kapadia sir, he has been awarded Dr. Abhay S. Dixit Oration. So I will request Dr. Kapadia sir and request Dr. Abhay Dixit, Dr. Samir Shah and Dr. Pragnesh Shah to give over the award and bouquet to Dr. Kapadia sir. Thank you, sir. Now for the FFPI Best Unit Trophy. First category above membership above 100. The first prize goes to FPA Bangalore. I will request team FPA Bangalore to come forward and accept the trophy. I will request our Chief Guest Dr. Samir Shah sir and join all the colleagues to felicitate team FPA Bangalore. The second prize goes to Family Physician Association Rajkot, FPA Rajkot. Please team Rajkot come forward fast. Next, Bhavnagar, be ready.
टेनिस मैच था एब्सेंट वाला पकड़ाई दी એવું તમે કહેજો મારે મને ખબર નથી. હા હા શ્યોર. એટલે સ્ટેજ તૂટી ના જાય જોજો હો. Success has many fathers. રાજકોટ મજામાં? Thank you, Team Rajkot. Now the second category, Best FFPI Unit Trophy for membership less than 100. And the award goes to FPA Bhavnagar. Team Bhavnagar, please come forward. Now, next we'll go for the installation ceremony. I will call all the names one by one. Please come on stage, accept your trophy and stand by the side of the stage. Do not go back in the audience. Stay here near the stage. Quickly we start with the Central Executive Committee first. EC committee फटाफट लाइन में 3-4 આપી દો EC committee. Now we'll start with the installation of EC committee. First is Dr. Dhirendra Sadandia from Ahmedabad, Dr. Prabhakar V from Bangalore, Dr. K.N. Harish Kumar from Bangalore, Dr. Dinesh Goyal from Bhavnagar, Dr. Naresh Joshi from Gandhidham. All 5 of you, please come fast. Sir, thank you very much. Dhirendra Sadandia first. Dr. Prabhakar. Here, okay. Next 5, Dr. Manilal Patel, Dr. Jigdekar, Dr. Ashok Rasalkar, Dr. Preeti J. Shah, Dr. Babulal Sutaria. Just stay here. Dr. Harish Kumar sir, stay there, below the stage. Just stay there, yes, don't go. Naresh Joshi area chair. Manilal Patel, next is Manilal Patel. Dr. Jigdekar is sitting there. Babulal Sutaria. Next 5, Dr. Vineet Jagani, Dr. K.N. Selaria, Dr. Ramesh Jain, Dr. Ashish D. Patel. Goyal sahib, please be here, remain here. Goyal sahib, don't go in the audience, stay here. Joshi sahib, come forward, don't go back, come forward. Manilal sir, be here. This side. Dhiren, બધાને પકડીને ઉભા રાખ. સંજય ભાઈ, કોઈ જવા ના દેતા, અહીંયા ઉભા રાખ. Dr. Rikul Shah, Dr. Nimesh Desai.
યાર ડિસ્પ્લે નહીં થતું હવે તક બસ ઈસી પતી ગયું ઈસી જવા દે ઈસી ઓવર હા રાખો હમણાં અચ્છા હા પેલા નામ હતા ને ઉભા રહો અરે યાર ડોક્ટર રામલાલ લીલા ડોક્ટર
Respected doctors, please be seated. We will have another lucky draw session after this. Please be seated.
રાજકોટના નામ લખ ડોક્ટર ગુપ્તા ફ્રોમ ઇન્દોર ડોક્ટર લીલા સર કરતા ડોક્ટર કાસુંદ્રા ફ્રોમ રાજકોટ આવી ગયા બસ દેટ્સ પણ નથી કોઈ તો શું કરે ડોક્ટર મનીષ જૈન ફ્રોમ ઇન્દોર નોટ ધેર ચલો કઈ નાઉ ટાઈમ ફોર આસિસ્ટન્ટ જોઈન્ટ સેક્રેટરીઝ ડોક્ટર જનક શાહ આઈ થિંક સર ઇઝ ધેટ ડોક્ટર સંજય શાહ આસિસ્ટન્ટ સેક્રેટરી ડોક્ટર સંજય શાહ તમને એમ આપી દઈશ ડોક્ટર સંજય શાહ Next is Dr. Yatish Lapsiwala, Dr. Hiren Mehta. These all four are assistant secretaries. Then we'll have four vice president, Dr. Preeti Shankar from Bangalore, Dr. Vibhakar Adwari sir from Mumbai, Dr. Nitin Shah from Vadodara, and Dr. Deepak Torawala from Surat. Preeti Shankar is here. Apo Preeti. Rajneesh bhai, फटाफट ग्रुप फोटो. एक ग्रुप फोटो पाडी बाकी पती गયું છે. Now last. एक पति गયું છે. Preeti, Dr. Preeti, please stay back. Stay here. ના ના આપણે અહીંયા સાંભળો ઓફિસ બેરર ઉપર ઈસી વાળા લાઈનમાં આગળ. ડોક્ટર મેહુલ શેલર કમ ફોરવર્ડ. આપણે ઉપર કમિટી નીચે. I will request all the executive committee members to make a line in front. Yes, एक अमित भाई एक ब्लैंक आपो. Blank moment. Office bearer will come on this stage. The executive committee members will form a line in the front. We are going for a group photo. All are requested to sit because there are exciting 55 gift lucky draw after this 2-3 minute session. Those who are in the room, they are only get the gift, eligible for the gift. So please be there in the room.
official photographer is pending, wait. Thank you. Thank you.
હવે જેને જે કરવું એ કરે.
સર માઇક ચાલુ છે.
Thank you, friends. Whatever scientific feast, knowledge, fun, masti, cultural activity you enjoyed during this conference, it is basically a teamwork, so it is unfair if we don't recognize the team. So I request Dr. Moment open, I request Dr. Samir Shah